Good morning, everyone.
Good morning, ma'am.
All the seniors, juniors, colleagues, everyone. A very good morning. And at the outset, I would like to thank Dr. Anitya Shrivastava
Thank you, ma'am.
for giving me this opportunity to share our knowledge. Okay, so these are the three divisions of the skull base. So the anterior, I am going to talk more on anterior skull base. So anterior skull base extends from the posterior table of the frontal sinus posteriorly up to the lesser wing of the sphenoid. So this yellow part is the lesser wing of the sphenoid. So essentially the skull base, anterior skull base consists of the orbital plates of the frontal bone, the cribriform plate, the crista galli, and this is the lesser wing of the sphenoid and the anterior clinoid process. So this is the anterior cranial fossa and it lodges the frontal lobe and the olfactory bulb. This is the middle cranial fossa and this is the posterior cranial fossa, as we all know. But how do we divide the posterior from the lateral skull base? This is based upon this petro-occipital suture line. Okay. So the part that is lateral to the suture line is the lateral skull base and the one which is posterior is the posterior skull base. Alright. So this is the anterior skull base. We've already discussed this. So the endoscopic central skull base approach is to what all structures? So starting with frontal sinus, cribriform plate, the olfactory bulbs, frontal lobe, then the ethmoid roof, sphenoid sinus, pituitary gland, suprasellar region, cavernous sinus and the midclival region. So this is the central skull base. Right, so what is CSF rhinorrhea? So CSF rhinorrhea is the leakage of CSF due to the osseous defect in the skull base along with the defect of the meninges. So that leads to the prolapse of the meninges, the dura and the arachnoid, as well as in some cases the brain tissue also, so when it is called encephalomenincocele. So the disruption of dura occurs, but when there is no displacement in the osseous defect, it generally heals, like in traumatic cases. But the leak persists if the healing of the dura is not at par with the healing of this bone. Alright, so there will be a permanent fistula. Now significance, since there are so many, the incidence of road traffic accidents has increased so much, so we also see these CSF rhinorrhea cases, a lot of these cases in our OPD also, right? As the traumatic cases, they constitute about 80% cases, right? 80% cases of CSF rhinorrhea are because of road traffic accident. Rest are iatrogenic or spontaneous. So immediate repair within 2 to 4 weeks is ideal in cases of trauma, but it is said, or according to Professor P.J. Wormald, it should be repaired beyond 10 days, right? We can wait for 10 days for conservative management and after that we should take it up for surgery, right? But the delayed onset cases also can be managed surgically. It's not just the immediate cases or the acute cases, the delayed cases also can be managed. I also have to deal with meningoencephalocele, so few words about meningoencephalocele. So this encephalocele can be congenital and it can be acquired also. Acquired in cases of like CSF rhinorrhea, or it can be congenital because of the neural tube defects. Okay, when the ectoderm fails, when the neuroectoderm fails to lose communication with the outer epithelium. So a sac containing the brain, the meninges and the CSF forms outside the skull through a bone defect. Acquired encephalocele may result from trauma, tumors or iatrogenic injury. And anterior encephalocele. So anterior encephalocele develops when there is loss of fusion between the frontal bone and the nasal bone. Okay, there is a persistent foramen cecum. Okay, that does not close, so that leads to cases of anterior encephalocele, right? A diverticulum of dura usually projects anteriorly, so this is embryologically how this defect occurs. So a diverticulum of dura usually projects anteriorly between the developing nasal and the frontal bones at the level of the fonticulus frontalis and foramen caecum. So foramen caecum is present at the anterior end of the cribriform plate. Okay, it is the anterior end, and fonticulus frontalis, it is the space embryologically between the frontal bone and the nasal bone. So when this space does not obliterate, the persistent dura and the meninges may present in life as encephalocele. Okay, so the types of anterior encephaloceles: sincipital means anterior. There could be occipital encephaloceles as well. So sincipital are generally nasofrontal, that is between the nasal bone and the frontal bone. Could be nasoethmoidal, between the ethmoids and the nose and the nasal bone, and nasoorbital. So nasoorbital presents at the lateral end of the cribriform plate or at the lamina papyracea level, right, where the frontal process of the maxilla joins with the ethmoid. Okay, so at that level the nasoorbital encephalocele may present. And the basal encephaloceles, they generally occur along with CSF rhinorrhea. So it is usually occult. Okay, they don't present outside. It is usually occult. When we examine for CSF rhinorrhea, then we find these encephaloceles, or radiologically, or on blocking the internal jugulars, both the internal jugulars, or by Valsalva. So it increases. So that is how we clinically diagnose a encephalocele. And it is a skin covered mass. So those involving the intranasal area can cause nasal symptoms like obstruction, snoring, CSF leak or meningitis. And the most common site of anti-encephalocele is the cribriform plate, followed by the ethmoid roof and sphenoid or sella. So the treatment of encephaloceles, we all know it is surgical only, and in congenital ones it is generally the sincipital encephaloceles that are treated generally by open approach. Okay, endoscopic ones are those which are associated with CSF rhinorrhea. Mostly we manage those with endoscopically. So the goals are to repair the bony defect with a watertight dural closure, eliminate the excess skin, and remove the non-functional brain tissue, because mostly whatever the brain tissue has prolapsed into the encephalocele, it is non-functional or it is non-viable. So we can easily excise it, and of course if it is significant, then we have to take a neurosurgical opinion also, because the contents might include nerves like optic nerve, or there could be vascular structures also. So we have to take a neurosurgical consultation also. Okay, so now coming to the anatomy for CSF rhinorrhea. We all know that the brain is covered by the meninges. The outermost is the dura, then is the arachnoid, and then is the subarachnoid space which is filled with CSF, and lastly closer to the brain is the pia mater. So the subarachnoid space contains the CSF fluid. So there are two kinds of fluid spaces of brain. The internal fluid space is the ventricles with choroid plexus, and the external fluid space is the subarachnoid space containing CSF. So the CSF is continuously being produced in the brain, it is being reabsorbed, and then it enters the venous system, and it circulates around the spine as well as the brain. So the functions of CSF: since brain is a soft structure, it does not have much support, so the CSF helps to give it some kind of rigidity, it helps to maintain its shape. Okay, and also it prevents as a shock absorber, protective water jacket, and it regulates the chemical environment of the brain by removing the byproducts of metabolism. So we all know there is a blood-brain barrier, so substances can go from brain to blood but not from blood to brain. So where is the production? The production is 60% by the choroid plexus, okay, and rest is extrachoroidal by the ependyma. So it is in the floor of the lower horn of the lateral ventricle, then the roof of the third ventricle, and the floor of the fourth ventricle. Right, you can see this. And how does it circulate? So it forms in the choroid plexus, and from the lateral ventricle it enters the third ventricle through the foramen of Monro. Okay. So this is just a recollection of our neuroanatomy that we've all learned. So, and from the third ventricle, it enters the fourth ventricle through the aqueduct of Sylvius, right? So this is the aqueduct of Sylvius, and this is the fourth ventricle. Once it has entered the fourth ventricle, it moves out into the cisterna magna. Okay, so this is the cisterna magna. It is a space, subarachnoid space. It's a large space of subarachnoid, and this moves out into the cisterna magna through the foramen of Lashka and foramen of Magendie. So Magendie is in the center, and there are two foramen of Lashka. So it will enter the subarachnoid space now. So it bathes this entire cerebrum, and it will circulate like this and into the spinal cord, around the spinal cord. Now this is the primary circulation. Now where does it get reabsorbed and entering the venous circulation? That happens here. These are the arachnoid granulations. Okay, so from these, and these project into the dural venous sinuses. So through the arachnoid granulations, it will get absorbed into the dural venous sinuses, and from the dural venous sinuses, it enters the internal jugular vein and finally into the venous circulation. Okay, so, and these arachnoid granulations, they are absent in the floor of the middle cranial fossa, right? So we will see the significance of that when it is absent in the floor of the middle cranial fossa. So this is the actual picture that I have taken from the net. This is the lateral ventricle. You can see the lateral ventricle, the lower horn, and that is the choroid plexus, which is made up of, this is the microscopic structure. These are the ependymal cells, and inside are the vessels. Okay, the vessels and the cells, and this is also ependymal lining. So 60% is from the choroid plexus, and rest of it is from the ependymal cell, from the intracellular water. So that is how the CSF is constituted. So how CSF circulates, we know now. This is the lateral ventricle, this is the third ventricle, this is the fourth ventricle. So the amount of CSF produced in a day is 500 ml per day. Okay, but the total amount of CSF that is there is only 150 ml. So multiple times it is being produced. The intracranial pressure, this is important. The intracranial pressure is 5 to 15 centimeters of water. So if there is increase of this intracranial tension more than 20 centimeters, then it has got implications for CSF rhinorrhea also. So sustained intracranial pressure more than 20 centimeters water can cause weak points. There can be local erosions because of the sustained pressure. Alright, and also the pulsations. How do the pulsations come? What causes these pulsations of the CSF? That is the circle of Willis. Many vascular structures that belong to the circle of Willis, they are present in the cisterna magna, right? So that transmits, that gives the transmitted pulsations of CSF, which we see in CSF rhinorrhea. So the etiology is divided into traumatic and non-traumatic. So traumatic is the most common. 80% cases are traumatic because of the road traffic accidents commonly, and the trauma could be accidental or it could be iatrogenic also. During surgery, most commonly FES surgery or acoustic neuroma surgery or pituitary surgery that can give rise to iatrogenic trauma. Non-traumatic, most common site is cribriform plate. Alright. So cribriform plate is the commonest area. So whenever one is not able to localize the actual site of leakage, we explore the cribriform area and we repair it also. So high pressure leaks, there could be high pressure leaks because of trauma or because of hydrocephalus. And normal pressure leaks, they are also called spontaneous leaks. They are very rare. They are 3 to 4% only, right? So normal pressure leaks could be because of focal atrophy, local erosion, point erosions can take place, or olfactory. Olfactory, we know there are 20 filaments, olfactory fibers that enter from the cribriform plate, and they carry along with them the dura and the arachnoid. So if this dura and arachnoid, it becomes filled with CSF, so it will prolapse and give rise to CSF rhinorrhea. So olfactory, then congenital anomalies, congenital anomalies are there are persistence of dehiscences. Okay, there could be dehiscences like lateral craniopharyngeal canal, which we also know as Sternberg's canal. So, in relation to CSF rhinorrhea, there is lot of discussion about the Sternberg's canal. So, but now there's a lot of controversy also. But the present opinion is that there is nothing like Sternberg's canal, and it is just the erosion only that gives rise to CSF rhinorrhea. Earlier, the leaks from lateral recess of sphenoid, they were all attributed to this Sternberg canal. Okay, but not all of them are Sternberg canal. There are very few cases of Sternberg canal, and we'll see where the location is. So the lateral craniopharyngeal canals or the abnormal diaphragma sellae, right, in the sella turcica. So the diaphragma sellae should close this sella turcica, but when it is abnormal, the dura prolapses into the sella, and when there is prolapse of dura, it will also carry along with it CSF. So the CSF sac is there in the sella turcica, which presses the pituitary. On pressing the pituitary, the functions of the pituitary could be hampered, may or may not be hampered, and this gives rise to the empty sella syndrome, okay, which we see as an incidental finding also on MRIs. So on MRI we will see a sac filled, a white colored this thing in the sella instead of pituitary. So that is empty sella syndrome. That is also one of the causes of CSF rhinorrhea. Okay. So cellar is this pituitary, any defect in the pituitary, either because of the surgery or otherwise because of the focal erosions, that can give rise to CSF rhinorrhea. And then osteomyelitic erosions, right? So osteomyelitic erosions can also give rise to infections and tumors like nasopharyngeal carcinoma, angiofibroma, okay, or infections like osteomyelitis. They can also give rise to erosions of the skull base and CSF rhinorrhea. So the diagnosis, first of all, we have to be clear whether it is a CSF leak or not, okay, whether it is nasal secretion or it is CSF. So the presence of leak to be confirmed, right? Then what is the cause of the leak and what is the site of the leak? To address the leak, we have to know the site of the leak also. So a good history means persistent rhinorrhea post-trauma, that has to be considered CSF until unless proven otherwise, right? Then repeated attacks of meningitis, that may not be very common, but the commonest presentation would be unilateral clear watery discharge. So that we have to rule out whether it is CSF or it is this thing, yes, allergic rhinitis. So, and handkerchief, we all know handkerchief test, right? And patients, a lot of my patients, I have asked the patient's attendant also whether they could perform this handkerchief test, and they tell clearly whether it is soft or whether it is crispy, yes, stiffened after drying. So this is a very good test when you have to ask the patient or the attendant, or they can't do it right in front of you. So they will tell handkerchief test, then increased discharge on bending forwards. So this is again, we can ask the patient to bend forward. If it is an active leak, then you can ask the patient to bend forward for some time, or block the jugulars, or ask the patient to perform Valsalva. So in that case, you can see the increased drip. Valsalva maneuver, reservoir sign. So reservoir sign is nothing but the collection of this thing in the sinuses, like the sphenoid sinus, it gets collected. When you move forward, then it starts dripping. So that is also called as teapot sign. That is also teapot sign. Okay, when you bend, yes.
Is it possible sporadic incidences in the same patient? कभी अचानक से
yes, that is possible.
एक drop गिरा है.
हाँ, that is possible. See, if it is not leading to meningitis, very sporadic, say the episodes are after a few months, okay, and it is not leading to much of meningitis, repeated infection.
No
so
symptom, just during studying a drop comes. 2 or 3 drops come.
That you can manage conservatively also. Okay, if it is repeated, then of course there is a risk of meningitis. What is the immunity status of the patient also, and then we can go for radiology. And if we see a clear-cut defect is there, and the dura is also not continuous, in that case we should explore and repair.
CSF analysis do we have in UP?
No, CSF analysis you can get done simply by the this thing. You can just look for proteins, sugar, the cells. That can be done. Yes, everywhere. That is everywhere. That you can get it done everywhere. Only beta 2 transferrin is not there. Beta 2 transferrin is not there. I got in one of my patients, I got this beta 2 transferrin done luckily by SRL Ranbaxy. They were doing it, but that is long back, I think 7-8 years back. After that, even I couldn't find anybody who could do this. They even Lal Pathology and others.
Bengal mein they are doing.
Acha, maybe.
They are doing only from there. They are only doing
No,
in
but
Bombay.
acha, maybe.
Maybe. In KG we used to send the sample to Bombay.
Bombay.
One of the labs sent it to Bombay, and then from there we get it.
Which labs? Any idea? Because I'm also at totally lost when we have to do beta 2 transferrin. So we can go for beta tracer proteins, right? And CSF analysis is the best. It is cheap and best. You can just send the fluid for the analysis for protein, sugar, and that, and you can make out it is CSF.
How much will be required? Like if 1-2 drops are there.
Of course, that is too less, but I
and
think.
that too, the drop comes, then it won't come.
So if it is so less, just ask the patient for conservative measures, okay? Because a lot of patients they resolve by conservative means. So if it's a very small defect and suppose it heals only, and why to go for the surgery in the first attempt only? So we can wait and watch. One of my patients and they are distributed over a 1 year time. So I'm just watching and I got the radiology done. The defect, osseous defect is there, but the dura has repaired. Dura has healed. Okay, so the dura is covered. So that is why we'll just keep them for on watchful observation. Okay, we don't go for surgery right away. So headache, high pressure or low pressure, both kind of headaches can be there, and hyposmia, audiovestibular symptoms in cases of CSF otorhinuria. Then the cause of leak, most common cause post-operatively is incidence-wise is transsphenoidal excision of pituitary tumors. Alright, 0.5 to 15%. Then acoustic neuroma surgery and FES. Right? Empty cellular syndrome is found to be associated with meningoencephalocele and CSF leak, and also pituitary tumor necrosis leading to benign intracranial hypertension. Alright, so benign intracranial hypertension is also one of the entities that leads to CSF rhinuria. So what is benign intracranial hypertension? Nowadays it is known as idiopathic intracranial hypertension. But there is no obvious cause. Okay, there is no congenital anomaly, there is no tumor, so there is no obvious cause, but the patient will have papilledema. Patient can complain of headaches also. So in that case we label it as benign intracranial hypertension, and as long as the CSF leak is there, the patient will not have signs of hypertension. Yes, pressure is being released, but the moment you repair it, then the patient has this hypertension and the symptoms also, and there is high likelihood of failure. So we have to manage. So it is generally diagnosed after surgery when there is failure. So in that case we have to manage this hypertension also by ventriculoperitoneal shunts, VP shunts. Then the management protocol, first of all a good history, right? Then examination, CSF analysis. I have not written, but CSF analysis is important because I send it first for CSF analysis only. Beta 2 transferrin can't get it done. Beta trace protein can be done. Then because we'll see, diagnostic nasal endoscopy is also a must, because in diagnostic nasal endoscopy one can see the one can see the site of leak, one can see the pulsations and the dura prolapse also. So it is very clear cut generally. Unless it is in the cella, you can't see. But critiform plate and fovea, you can see. So CT MR cysternography, again it is a good investigation rather than getting an HRCT done unless the patient has some kind of allergy to these dyes, yes, contrast material, or the patient cannot afford. So in that case, CT cysternography is the best, okay, because it shows the actual leak, the contrast. Otherwise, HRCT also can show the leak and the dural prolapse. So CT MR cysternography, it is positive, then surgical repair. If it is negative, then we go for the dye, the intrathecal fluorescein, right? So intrathecal fluorescein is done, the patient is made to lie in the prone position, and then we do an endoscopy and see the leakage of the dye as a yellow colored fluid. Then if it is positive, then surgical repair. If it is negative, again then we keep the patient and follow up. So the biochemistry CSF analysis, the opening pressure 5 to 20 centimeters of water, blood sugar levels are 2/3 of the blood serum level, right? So it is not 30, it is 50 to 80. Some mistake. CSF protein is 15 to 60 milligram %. WBCs are less than 5 per microliters, and it is generally lymphocytes, and there are no polymorphs, hardly any polymorphs are seen. So this is a typical CSF. So the analysis is a good indicator of CSF rhinorrhea. Then beta trace protein, it is only found in CSF, while beta 2 transferrin is present in other places also, like the perilymph and the vitreous humor. There is hardly a chance that these fluids may be present along with CSF. So it generally is considered to be a CSF leak only, but beta trace protein is the most abundant protein in the CSF. Then localize the leak, that is the most important thing, to localize the leak. The site, the size and the side of the leak is important. Then HRCT scan brain and PNS, axial, coronal and parasagittal sections. They help to show the leak because the osseous defect can only be seen on the HRCT along with the prolapse of the dura. So soft tissue density will also be there. Then CT cysternography, it is complementary to HRCT. In case you are not able to localize in the HRCT, then we can go for CT cysternography. So, but this is important only for active leaks. Inactive leaks will not present. Frontal and sphenoid reservoirs, it is indicated in when there is no site identified on HRCT, and for identifying active leak in multiple bony defects. So which of them is actually active, that we can know through cysternography. Then MRI non-contrast and MR cysternography, it distinguishes inflammatory from meningoencephaloceles, and it is important for active leaks as well as intermittent leaks also, because you will find the collection of the CSF in the sinus, in the particular sinus. White liquid, white fluid. So the spontaneous leak patients with no bony dehiscence and no opacified sinus, cribriform area is likely to be the site, should be explored and repaired. So navigation, again for those who have navigation, they can easily localize with the help of navigation by the CT scans done as per the navigation protocol. Radionuclide cysternography also can be done, but then again there is a hazard of exposure to radiations. So in that case, technetium and indium 111 DTPA is used. Then intrathecal dyes, so 5% fluorescein is used, which is diluted. 0.2 ml is taken, it is diluted in 10 ml of either normal saline or the CSF only. CSF is withdrawn and then it is diluted 1 hour prior to the surgery. Active leak will show bright yellow CSF dripping from nose, and with blue filter in the light source, one can see it as a fluorescent green. Then coming to the management, conservative management is equally important. Like you said, intermittent leakage. So conservative management also helps the defect to heal. Okay, by keeping the patient on bed rest, the head end is raised 15 to 20 degree, avoiding straining and lifting any heavy weights. Okay, so or putting lumbar drain also. So not everybody prefers to put lumbar drain, but it can be put for 4 days, and about 150 centimeter cube or ml for 4 days can be withdrawn. Okay. So an antibiotic coverage is given to prevent any meningitis, episodes of meningitis or secondary infection. Then diuretics, the best diuretics are thiazides or astazolamide. So I've also seen people giving lacilactone or spirolactone, but astazolamide is said to be in the literature one of the best diuretics to keep the pressure down. Surgical therapy. Now surgical therapy in traumatic leaks close within 2 to 4 weeks. Okay, but according to PJ Wormald, he advocates closure if leak persists beyond 10 days. Right? So in iatrogenic trauma, best is to repair intraoperatively. If we have identified, while doing PES, one can identify whether the leak or whether any defect has been made in the skull base. If you are not able to identify the skull base and we keep opening the cells, considering the skull base also as one of the cells, then sometimes inadvertently one can open up the skull base also. But in that case, the best thing is to close it there and then. Even in mastoid surgery, sometimes it happens that you open while drilling, you open the dura also. But in that case also it is best, you have got temporalis fascia, you've got cartilage, so it is best to do an underlay and block it. Okay. So I think the best thing is to repair there and then, rather than explore later on in the scar tissue and all. So it is best to repair intraoperatively, and if it is discovered in the post-operative period, then first try for conservative means. Alright, in case of associated pathologies like tumors or high pressure conditions, lesions should be treated first to control the pressure first and then manage the CSF leak. Indications for closure are refractory cases not responding to conservative treatment, then spontaneous leaks, recurrent attacks of meningitis despite an inactive leak, intraoperative leaks, extensive trauma or profuse leak. Then surgical techniques. So there are various factors which we have to keep in mind when we are going for a surgical management. That is whether we need to put a lumbar drain or not. Right? So lumbar drain is generally put for only 3-4 days, because if you keep it for excessive time, it may give rise to pneumocephalus, infection, headaches, okay, low pressure headaches also, right? And sometimes other conditions also like vocal cord palsy and all, because of the low pressure, right? So approach for repair, what should be our approach for repair? So once we have identified the site of leak, then we can make an approach. We can consider what are the approaches we have, and then what is the graft that we are going to use or the flap we are going to use to repair. So that depends upon the size of the defect. So if the defect size is more, then we will be needing other flaps also, pedicle flaps like nasoseptal flap, Haddard flap and all. Sealant, whether we have the sealant, because not everybody has the facility of a sealant, not everybody can get. So many of my cases I did without sealant only. So, but if you have this luxury of a sealant like T-Seal and all, then one should use, okay, for a good watertight closure. And nasal packing, of course, is important to give support to whatever repair you've done. So, and moreover, when we keep it for 24 to 48 hours, so that time some kind of adhesion has taken place. So that is why then after, or you can keep it for 3-4 days also, and then after that you can remove. So that will not displace the graft. So the materials used are fat, like that is the biggest proponent of fat is Professor PJ Wormald only, bath plug technique. Then fascia, temporalis fascia or fascia lata. Bone can be used, cartilage, lyophilized dura, hydroxyapatite, pedicled mucoperiosteal flap, mucosal flaps, free flaps also, recombinant human basic fibroblastic, fibrin glue, autologous dura or synthetic dura. So neurosurgeons generally use this a lot. Surgical approach, intracranial, extracranial. Intracranial is generally by the neurosurgeons only, but the drawbacks of intracranial are that one has to do a lot of retraction of the brain. So retraction of the brain leads to sometimes epilepsy also, right? So intracranial is generally avoided, so that is why the focus is more on endoscopic approach and good coordination and collaboration with the neurosurgeons. So non-endoscopic, extracranial approach, non-endoscopic, transnasal or transfacial. So this approach, generally we go for endoscopic approach, but non-endoscopic approach may be required in cases where, like frontal sinus. Okay, frontal sinus, it is difficult unless you do a modified Lothrops. It may be difficult, so in that case, we can do a osteoplastic flap procedure also. Okay, or more extensive anterior skull base defects. So endoscopic repair was first used by Weigand in 1981. It is always done under GA. And lumbar drain, if done at the time of surgery, then 150 centimeter cube per day is removed. Only this much of CSF is removed for 2 to 4 days. And the position is supine with 30 degrees head up. So the exposures and the axis. So when the site of leak is planum sphenoidal, sella or medial cubiform plate. So planum sphenoidal we saw in the lesser wing of the sphenoid, just behind the cribriform plate up to the clinoid process. So that is the planum sphenoidal, right? So and sella turcica and medial cribriform plate. For that we can use a medial approach, right? Then transethmoidal anterior for the anterior fovea ethmoidalis defects and for lateral cribriform plate. So transmaxillary pterygoid approach is generally meant for the lateral recess of sphenoid. Then transethmoidal posterior is meant for the fovea ethmoidalis, posterior part of the fovea ethmoidalis, and the middle and the posterior thirds of lateral cribriform plate. So these are the approaches. Then preparing the site. First, of course, we have to localize the site, which we have to address. So the washout sign we look for. Washout sign is nothing but the dripping of the CSF. Okay, the CSF coming out from that particular side. That is the washout sign. And pulsations we see. Again, these are transmitted pulsations from the vessels of circle of Willis. Then use of fluorescein. We can use the fluorescein if we are not able to localize. Then we can use fluorescein also. And the anesthetist can also increase the intrathoracic pressure by Valsalva maneuver, and then we can see a better flow of CSF. Or we can identify the meningoencephalocele or the meningocele. The dura and the arachnoid we can see prolapsing. So denude the area around the site of leak about 1 centimeters to promote osteogenesis. So that is the site preparation for the flap that we are going to put in intranasally, right? So we have to denude, we have to localize the margins of the defect. Until unless we remove the dura properly close to the skull base, we cannot delineate the defect area or the bone, because the bone is the place which will take up the graft. If the dura is present or if the mucosa is present, it may or may not adhere. With dura it will not adhere, but if you place it over the mucosa, then there are chances of mucocele formation underneath, right? So avoid mucocele formation. So remove the mucosa all around. Then fat is, if we are using fat, the bath plug technique, then fat is plugged in or simply inserted, like in cribriform plate, or according to Professor P.J. Wormald, large defects can also be covered by this thing, fat plug, right? But this bath plug technique, it requires that the dura should be elevated. If the dura is not elevated, there is not enough space. If suppose there is a meningoencephalocele, then what happens? Brain, it adheres to the bony margins. And when there are adhesions, you cannot easily remove it. So the space is very less. So the fat will not enter there. So in that case, even Professor P.J. Wormald, he advocates fascia lata or some kind of fascia, underlay technique. Alright. So fascia lata is taken twice the size of defect, and fibrin glue is placed after each layer. Suppose we have put one fascia, then we can put a mucosal graft, or we are putting a Haddad graft. So after every layer, we put some fibrin glue. Then frontal sinus leak requires modified Lothrop. We have to open up the entire, both the sides, remove the septa so that to visualize it, and then we remove the mucosa, because again mucocele formation can take place. So the mucosa of the posterior table is removed and it is obliterated, a new fascia is put, and again fibrin glue, and it is obliterated with fat. Okay, so that is how we manage frontal sinus leaks. Then the type of grafts and where do we use. So the type of grafts may be overlay, as in tympanoplasty we all know. Overlay is when the dura is adherent. You cannot move the dura inside intracranially. So in that case we just place an overlay graft after proper preparation of the bed. Then inlay or underlays, dural fibers can be elevated and graft is placed on the cranial side. Then bath plug technique in the cribriform area and the fovea. So we all know the bath plug technique. We take a fat. The fat is harvested from the best preferred sites are the thigh or the earlobe, because it is fibrous and it is well knit. The fat cells are well knit, while the abdominal fat that is very loose, it is not very fibrous. So the preferred areas are either while you are harvesting the fascia lata, there itself you take the fat, or from the lobule also. In small defects you can take it from lobule. So in bath plug we take a long strip of fat about 2 centimeters long, take a stitch of 40 vicryl at one end and pass it through the length of of the fat plug, insert it, and then we pull it so that it sits on it and it seals the defect. Then coupling is used in sella or clivus. When we are dealing with the sella or clival defects, in that case some people use coupling. Coupling is like 2 layers of fascia and in between is the dura. So one is above the dura or the subdural and one is extradural. So it is a coupling kind of a thing. Then cartilage or bone, larger defects require support from cartilage or bone, more than 1 centimeter. So small defects are generally less than 1 centimeter and more larger defects are more than 1 centimeter. So multiple larger defects of fovea and sphenoid, and obliterative technique is generally used for sphenoid. Although nowadays even obliterative technique is also not preferred. The preferred technique is a good approach, right, and keeping the sinus pneumatized and open. Right? So, but obliteration was done in sphenoid sinus and also frontal sinus. So this is a diagram of the overlay technique. We can see the mucosal graft here. This is the mucosal graft outside. Cartilage or bone graft has been used outside intranasally, and the mucosal graft, free mucosa, is used. This mucosa can be harvested from the turbinates or from the lateral nasal wall anterior to the middle turbinate. So because generally for a good approach we need to remove partially the middle turbinate. So when we remove the middle turbinate partially, we can use the mucosa along with the bone also, or simply mucosa also, free graft. And this is the underlay technique where we can see intranasally dura has been lifted, cartilage or bone has been placed, and then outside mucosal graft has been placed after preparing a good recipient area. Here also we can see this is the facial lata inlay, and this is the nasoseptal flap, the Haddard flap, and this is the facial lata overlay and some bioglue, and then we pack it. This is the sphenoid side. So the materials for repair, pedicle grafts like the Haddard flap, we all know, which is based on the nasoseptal branch of the sphenopalatine artery, and free mucosal grafts like the turbinate mucosa, composite grafts of middle turbinate, bone and mucosa, then oxidized cellulose foam, exogenous materials like vicryl mesh, hydroxyapatite, and fibrin glue, which is made of fibrinogen, thrombin and calcium cofactor. So this is the Haddard flap, we all know. So the post-operative care, again complete bed rest, head end elevated, lumbar drain for 3-4 days, and then it is removed. Nasal pack is removed on the 4th day, so that sufficient time the graft gets to adhere to the defect. Then restricted mobility, head end is kept elevated, laxatives, no straining, avoiding straining for 3 to 6 months, bending down is prohibited, and saline nasal sprays. Then complications, spontaneous CSF rhinorrhea, again elevated BMI, lateral sphenoid leaks, extensive skull base defects, they increase the risk of recurrence. So there is some relation with obesity, females, and spontaneous CSF rhinorrhea. Okay. So headaches, bleeding, meningitis, fever, subdural hematoma, mucocele formation, and sinusitis. So subdural hematoma, this is generally fallout of too much of tampering of the brain tissue. When we are inserting the patch, so if you are manipulating it too much, or you are inserting the instrument too much inside, more than a few millimeters, then it might damage the vascular structures of the brain also and could lead to subdural hematoma. So it is advised that only a few millimeters it should go, and with small maneuvers the patch should be inserted. Sinusitis. Then the clinical pulse, most common cause is trauma, followed by surgery and followed by spontaneous leak. The most common site is fovea ethmoidalis, frontal sinus, lateral lamellar cribriform plate, and the sphenoid sinus. So what is the reason of lateral lamellar cribriform plate leakage? Why this is more common than the medial part? Yeah, this is the weakest point, because the anterior ethmoidal artery enters at this point, and this could be so thin, it could be as thin as 0.1 mm. So that is why this is the most common area. Then if inactive leak and recurrent meningitis, then explore cribriform area. And sometimes if the leakage cannot be located, so some people use a blanket graft, right, from anteriorly from the posterior boundary of the frontal sinus to the sphenoid sinus. A large flap or multiple flaps are placed so as to blanket cover the entire anterior skull base in case we are not able to localize. And spontaneous leaks may be associated with idiopathic intracranial hypertension. This also should be borne in mind, although it is a very rare entity. But if there is a recurrence of failure, then one should also explore this thing and look for fundoscopy and the opening pressure, lumbar drain. While putting the lumbar drain, what is the opening pressure and whether there are any papilledema or optic disc changes that we can look for, and complaints of headache. So this is one case that I presented in Rhinocon also recently, Bikaner. So this is a 54-year-old male who was farmer by occupation with complaints of nasal discharge, clear watery discharge from left nostril, increased on bending forwards for 3 years. So this was an old male, and his son brought us from an ophthalmic surgeon, and he was having continuous dripping, but it was not anteriorly so much as it was posterior, and he was having recurrent cough. Okay. So there was no relief on antihistaminics. He suffered from meningitis also. Post-nasal discharge and cough was there. Handkerchief test, I asked his son, so he said it becomes very soft. So the past history, the patient had history of left eye surgery following orbital abscess and periorbital blisters 39 years back, and there was loss of vision in left eye. Then trauma to head by brick 17 years back, so didn't look like traumatic. That is a long history. Then diabetes mellitus type 2 he was having. Meningoencephalitis he suffered in October 2022, and he was admitted in neurology. He was moving from his son, he was going from pillar to post for beta 2 transferrin. I sent him to Ranbaxy, then I sent him to some other pathology. I sent him to SGPGI, but he simply could not get beta 2 transferrin done. So in that case, I sent him for CT cysternography, which showed a clear-cut leak in the lateral. I'll share the CT also. So the defect was there. Then CMRI showed also CSF and sphenoid sinus. They did not mention it. So this was the video. This is a 20 minutes video of that repair only. So I think it would be nice if we see the video rather than only a lecture. So this is I presented it as modified endonasal endoscopic transpterygoid approach for lateral recess CSF rhinorrhea repair. Because the leakage, the defect was too lateral. So one approach is you just obliterate the sphenoid sinus, put the flap somehow and obliterate it. But that is fraught with lot of failures. So that is why I went through the literature, then I saw the technique how to do it, and then we did this technique. So this is the CT cysternography, and you can see this is the sphenoid sinus on this side. This is the lateral recess, the greater wing of the sphenoid and the pterygoid plates. Base of the pterygoid is nematized, well nematized, and this is the skull base defect, right, about 4.2 mm, right, and this is filled with the CSF fluid and the also meningoencephalocele. So this is the MRI. You can see this fluid filled in the left side, and so this video I have started from after doing middle meatal antrostomy, partial middle turbinectomy, partial superior turbinectomy, and anterior ethmoidectomy has been done. Now we are doing the posterior ethmoidectomy, mucosa of the posterior ethmoid, and then we will do the sphenoidotomy. This is the posterior ethmoidectomy. This is the maxillary antrum, you can see. So this is an important landmark for visualizing the maxillary nerve or the infraorbital nerve, because we have to stay every time medial to the infraorbital nerve. So this is the angled bipolar cautery suction forceps, and this is the most important instrument I think for such a surgery, because you can't use unipolar anyways. So this is the most important instrument. So I have cauterized the nasoseptal branch of the sphenopalatine artery, because I did not plan a Hadart flap here. So, and this is the Kerrison sponge, with the help of which we are removing the anterior wall of the sphenoid sinus. So this is the sphenoid sinus we've entered. You can see the meningoencephalocele here, right, from the angled this thing. So this is one defect. So I've removed the mucosa of the sphenoid sinus, and we are going as lateral we can. So this is the unedited video. That is why it is 20 minutes. So we are using the Kerrison sponge, which is safe, because as much as it can go inside and engage, we know that we are safe from the lateral wall or from the important structures. So this is the DNS that was blocking the vision as well as the illumination. So we did an endoscopic septoplasty to address this, and after that this corridor opened even more. So I've elevated the mucoperigontal flap, then the bone part. The bone and cartilage both were removed. This is a sphenopalatine artery area which we are cauterizing. This is the sphenopalatine artery. You can see the pulsations also. And this is the crista ethmoidalis, right, which we can remove and then cauterize the sphenopalatine artery. Now this is the part of the palatine bone, the crista, that we are removing. This is the sphenopalatine artery, you can see here, which will be cauterized. So this is a modified approach because I have not removed the posterior wall, the medial part of the posterior wall of the maxillary sinus. Otherwise, in the transpterygoid approach, one removes the posterior part of the maxillary sinus and the pterygopalatine space is opened up, the ganglion is lateralized, and then you approach the pterygoid base. So, but since we could get a good approach, a good access by just removing this crista, that is why I called it modified approach. So this is the anterior wall which still needs to be removed, anterior wall and the inferior part also. So this is the meningoencephalocele, you can see here. This is the sella and this is the clival part. This is again the meningoencephalocele and the lateral recess. This is the lateral recess, this is the partial septa, and this is the clival area, this is the sella. So the prolapsed brain part, that can be cauterized so that it shrinks. It goes inside the intracranial cavity and makes some space for any kind of underlay graft. So with the help of this cautery, we can shrink or we can excise this brain tissue. So you can see it is being shrunk. Even this needs to be removed. So that be removed with the help of the drill. So this has shrunken. The encephalocele has shrunken. And with the help of Freyr's elevator, we are removing the mucosa around it, making space for the graft. So this has shrunken, the encephalocele. So this we are seeing with the angled endoscope. So if we remove this, we can also see it with 0-degree endoscope. This is the encephalocele here. You can see this is the big encephalocele here.
Now this is 30 degree in the scope.
Now this is 0-degree.
0 degree.
Yeah. Sorry. No, this is 30-degree only. Because the wall is still there, this is 30-degree only. So with the help of cautery, one can also, if you are not able to remove the surrounding mucosa, we can also burn the mucosa and remove it. Like in cases of cribriform plate, where the mucosa is thin and the bone is also thin, so in that case we just cauterize the surrounding area and then can put the graft. So this is the rhinology drill. This is not a rhinology drill, it is a otology drill only, but we've used a longer burr. 12 centimeters diamond burr is there, so we used it and we put this thing, infant feeding tube on it. This is the defect. This is betadine actually here. So we've removed the entire anterior wall of the sphenoid sinus on this side, on the left side. So this area, as we could see in CT cysternography, this was inferior to the foramen rotundum and lateral to the foramen rotundum. If we run the CT scan, we can see the foramen rotundum. So the Sternberg canal, that Sternberg canal is said to be located above the foramen rotundum or medial to the foramen rotundum and inferior to the superior orbital fissure. But since this was very lateral, then it is not a Sternberg canal, it is just a skull base defect. And the area, this area of skull base defect, this is actually the middle cranial fossa area, right? So middle cranial fossa, it lodges the temporal lobe. So there is no dural venous sinus. So what happens? The arachnoid granulations that are there, they do not drain out into any venous system. So it keeps getting filled up with CSF. So when there is a lot of CSF, it makes point erosions, and that leads to such kind of defects, right? So the tissue has shrunken a lot, it has gone into the defect.
So what was this reason for the leak? Whether it was the trauma or the...
No, it was spontaneous, yes, because there was no obvious this thing. The trauma was also 17 years back, so that would not present so late. The patient had symptoms from the last 3 years, so that is doesn't seem to be correlated. So with the help of a flag knife, we are removing the mucosa, the surrounding mucosa, making it fresh. So this is the fat that we had harvested along with the facial atta. So the fat is being inserted into the defect with the help of the curved Freer's elevator. So we are pushing the fat into the defect. Now we can see it with 0 degree also. This thing is entirely open. This is the facial atta, a large amount of facial atta. So it is said that you should take the graft twice the defect size. So a large facial atta was taken and this was put on this thing over the fat. So we had procured the fibrin glue, the tissile, but somehow it got this thing. It did not work, it solidified a little bit. So we did not use the fibrin glue. So we just played a lot of layers. A large facial atta was placed. Once all the layers have been put, we should ask the anesthetist to give Valsalva or the forced inspiration to check if there is any leak. Okay, so there was no leak after Valsalva. And after this we place the surgery cell over it. Surgery cell on top of it, then Abgel, and finally the nasal packing with Merocil.
Ma'am, post-op, like after 4th day you remove the nasal packing.
Yeah.
Uske baad, what is the protocol that you follow at the institute?
We discharge the patient again, bed rest, head and raised, and Diamox. We give Diamox 500 milligram BD, and simultaneously, because this patient was elderly, he was diabetic also, so electrolyte monitoring was done. And after we called him after 15 days, then 1 month, then after 3 months, and then again 4 months, 10 months.
Ma'am, जैसे post surgery there is a lot of crusting.
Right.
उसके लिए ma'am
Nasal saline, yeah, no douching. So we,
ma'am, you like some people do endoscopy, call it in their minor OT,
okay,
do crust
removal of crust. Yes, we did call him in the OT, and then we used to do the endoscopy and remove all the crust and all. So this is Abgel, we place. So this is the post-op picture. This is 6 months post-op, and this is 10 months post-op. This facial atta, there is no pulsation, and it is healed well, and the sphenoid sinus is open. This is 0 degree endoscope only, and we can see the good pneumatized sphenoid sinus without any obliteration. So that prevents any further sinusitis or other kind of complications. The patient is fine now. We still call him after 6 months, right? So he's still in our follow-up, but he's fine. He's doing fine. All right.
Thank you.
So thank you so much. Thank you for your patient listening.
So basically today I will deal with the endoscopic approach to skull base. Before going for endoscopic approach, I just want to tell the basic anatomy of the very important to understand what is skull base. Because most of the complications occur during face surgery, which is commonly done by us, happen due to skull base injury. So we have to know which structure lies where. Basically, it's just like skull base separate from the intracranial cavity from your facial structure and neck. So basically, from where it started, skull base. So it started from anteriorly from the upper incisor teeth, posteriorly from the superior nuchal line. So basically, so this is your anterior to posterior, laterally from the remaining teeth and the zygomatic arch. So this is you are seeing from your like if you transact the skull and you are seeing from above. Okay. So if you see there are three compartment: anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. Anterior cranial fossa we will consider it from the posterior wall of the frontal sinus to lateral wing of sphenoid. Okay, so from this diagram not clear, I will show you other diagram. This is the frontal sinus, from frontal sinus to, and this is your sphenoid bone, and this is your lesser wing of sphenoid. From here to there is your anterior cranial fossa. Then from middle cranial fossa, where to where? From the lesser wing of sphenoid to the petrous apex part of the temporal bone. So if you see it, this is your petrous apex. Okay. So then posterior from petrous apex of temporal bone to the cranial cavity. Now these are the 5 bones which form the skull base, mainly ethmoid, sphenoid, occipital and parafrontal bones. So this is the like how the frontal bone and look like. Here you are seeing structure known as labella. Then supraorbital foramen. Supraorbital foramen passes few nerves, and along with that which nerve? Supraorbital nerve and trochlear nerve. If you are doing fast under local anesthesia, you are giving few blocks. One is trochlear block, another is greater palatine block. Okay, so greater palatine block I will tell you later, but yes, this is the structure where you will give block. Okay, see, now if you see it, we are talking about, if you remember, see, everybody, whenever I have to teach my PG student, I have to go through all the spot brown coming. So there is nothing same in learning. So what I want to say, if everybody remember one rule for anterior ethmoidal foramen and posterior ethmoidal foramen and optic canal, 24, 12, 6, rule of half, which we know. So what is that rule of half? This is the landmark of the optic canal from the posterior ethmoidal artery foramen. There was foramen, posterior ethmoidal foramen, through which posterior ethmoidal artery passes. Yes, this diagram is which I want to tell you. See, now if you are seeing through the orbit, you are seeing 2 foramen. Okay, this is your lacrimal fossa. Here you are seeing anterior lacrimal crest. So this is your lacrimal fossa, and the distance between from the anterior lacrimal crest to anterior ethmoidal foramen through which anterior ethmoidal artery passes is your 24 mm. Then anterior ethmoidal foramen, that distance is 12 mm. Then posterior ethmoidal foramen to optic canal is your 6 mm. Rule is half. Everything is getting half. Then what is the importance of this anterior ethmoidal foramen and posterior ethmoidal foramen? Why I am bothering about when we are talking about skull base? Because whenever we are dealing with the opening, see, we have to do the surgery, basic surgery for sinusitis, frontal sinusitis, during when we are widening the opening of frontal sinus. Now, anterior ethmoidal artery, why? It travels through the skull base, okay, then it enters to the orbit, okay, then it goes into the intracranial cavity once again. So, travel into the nose, then goes to the orbit, then goes inside again to intracranial cavity. Now, why I am bothering about this artery? Because if we are seeing the frontal sinus, it drains into frontal recess. Okay, frontal cyst, the boundary of frontal cyst anteriorly you see a thick bone known as frontal beak. Posteriorly, if you see it, you have to, there is sometimes agar nagi cell also formed anteriorly. Okay, so agar nagi cell and frontal beak relationship is which type? Agar nagi cell, can anyone tell? Yes. Why I am asking? Because I have to know how much I have to tell, because I cannot teach skull base in 1 day or 1 hour. I can. So it's the most anterior middle cell. So why you have to? It's an inverse relation. Larger the agar nagi cell and thinner is the frontal beak. Okay, अगर smaller is the agar nagi cell, thicker is the frontal beak. Okay, it's an inverse relation. Frontal is lie between these two structures. Okay, if you see it, CT scan in sagittal cut, because the brad is like and you lost the control and everything. You injured the cibriform plate and you will see. And second thing, if you are seeing any watery fluid coming, don't be panic. Instead, you just pack the with gauze, please don't do that. Refer आप कर सकते हो, ठीक है? You just first ask your anesthetic to lower down the intracranial pressure, है ना? Reverse tendon position. These things are basic thing. They will give mannitol whatever, है ना? Generally क्या होता है? कोई complication हुआ वहीं पैक कर दो, वहीं छोड़ दो. पेशेंट को अगर पैक ज़्यादा रहा तो meningitis हो जाएगा. You have to avoid packing in case of meningitis. Why I am saying? Because you know, अगर आप पैकिंग करोगे, आप जितना बीटाडिन वगैरह पैक कर लो, बीटाडिन से रिवन वॉश करके, बट देयर इज चांस इंफेक्शन कैन रीच टू द ब्रेन. यू हैव टू गिव आईवी एंटीबायोटिक. यस, अगर ब्लीडिंग विद सीएसएफ लीक है, देन यू कैन पैक इट with IV antibiotic coverage which can cross the blood-brain barrier, especially cephalosporin. So this is your cibriform plate. Okay, so cibriform plate have this thing you are seeing from the above. अगर cibriform plate का आप observe करोगे, it has medial lamina, lateral lamina, and one structure known as crista galli. Okay, now why I am bothering about cibriform plate? Because cibriform means like छलनी, आटा ऐसे छान के, तो इससे सारी olfactory bulb से सारी olfactory nerve passes होती. Okay, and most common site of CSF leak. Why? So it's the thinnest part of the skull base. ठीक है? This is medial lamina, this is lateral lamina, this is crista galli, CD. Okay, if you see that this thing, middle tablet generally attached at the junction of lateral lamina and medial lamina. Important point क्या है? आपका अगर CT मिलता है, you will check which thing? You will check the length of the lateral lamina. That is known as olfactory fossa. Okay, why? अगर इसका एक कीरोस क्लासिफिकेशन है, केरोस क्लासिफिकेशन है, याद है होगा किसी को, टाइप 1 1 to 3, टाइप 2 4 to 7, टाइप 3 मोर देन 8. ओके, नो क्यों? जितनी ज़्यादा लेंथ उतना ही ज़्यादा चांस आपका CSF लीक होने का. जितनी ज़्यादा बोन की थिनिंग होगी, उतनी ज़्यादा इंस्ट्रूमेंट आप अगर करोगे, देयर इज हाई चांस ऑफ लीकेज. जनरली क्या होता है, रेडियोलॉजिस्ट, देखिए मैं आपको फैक्ट बता रहा हूँ, यू हैव टू टॉक टू योर रेडियोलॉजिस्ट बिफोर गोइंग फॉर एनी सर्जरी या skull base surgery. I will tell you one thing, sir. I have seen all the bullshit report. Maxillary sinus haziness seen. Even a blind person can see. We are not bothering about. We have to know what is the condition of lateral lamina, what is the condition of this thing, length of the olfactory fossa, and we have to see the slope of the skull base. They have to mention this thing in the CT report. Nobody is mentioning. Hardly only few center they are mentioning the length of olfactory fossa or other thing. We discuss with the CSF lead. Since my topic is I am combining with the endoscopic approach plus anatomy. Okay, so that people can understand. suppose the CSF leak patient will come. Okay, so you have to investigate properly, है ना? Because this is the toughest thing to diagnose in India. Most of the time, I am telling once again, patient comes to you with any unilateral nasal discharge, one-sided nasal discharge, you have to rule out CSF rhino. Can be there bilateral if after RTA, आपका both side का क्रिब्रिफॉर्म प्लेट का फ्रैक्चर हुआ है, then it can be bilateral. But generally, second thing, अगर unilateral nasal discharge है, you should not send directly your patient to some other center कि PGI चले जाओ, रामनोर भैया चले जाओ. There are certain things you can detect by a history. ठीक है, पेशेंट कहेगा टी-पॉट साइन के बारे में बताएगा, whenever he or she will lie forward, it will start coming. Okay, but ये हर बार नहीं होगा, है ना, क्योंकि वो तभी होगा जब उसमें CSF कलेक्टेड होगा तभी निकलेगा. अगर एम्प्टी हो चुका है तो नहीं मिलेगा. ठीक है. दूसरा, एक क्लासिकल हिस्ट्री में बोल रहा हूँ जो नोबडी बॉदर टू आस्क, वेरी इंपॉर्टेंट टू से CSF लीक और नॉट. इंपॉर्टेंट चीज है, मतलब आप अगर नेजल म्यूकॉइड डिस्चार्ज है, आपका हैंकर की कड़क होगा, स्टिफ होगा, ड्राई होने पे CSF विल नॉट गेट स्टिफ. ठीक है. ओके. देन दूसरी इसकी, अगर ट्रॉमेटिक है तो आपको हेलो साइन मिलेगा, डबल विंग्स साइन. आपका सिंपल आपका टिश्यू पेपर है, उस पर आप देख लीजिए. लेकिन केवल ट्रॉमेटिक CSF लीक में आपको हेलो साइन मिलेगा, डबल विंग्स है. अदरवाइज नॉर्मल CSF लीक में वो नहीं मिलेगा. ब्लड होगा तभी मिलेगा, ब्लड मिक्स डिस्चार्ज. बट द हिस्ट्री ऑफ स्टिफनिंग ऑफ हैंडकरचीफ इज वेरी इंपॉर्टेंट, स्पेशली व्हेन वी आर इन इंडिया वेयर बीटा टू ट्रांसपेरेंट वी कैन नॉट सेंड इट इजीली. द गोल्ड स्टैंडर्ड इज बीटा टू ट्रांसपेरेंट. You or the sample will go to UK by a flight. The Lal pathology, the cost is around more than 35,000. Okay, the beta to transfer in the cost is around more than 35,000. If you talk to Lal pathologist, they will tell some sample तो भेजते हैं, but 30,000 cost investigation का plus flight का जो traveling का जो लगे. This thing is important कि भाई आपका है तो आपको ये देखना है. अच्छा जी, CSF चलो लीक आ गया, सबसे पहले आप क्या करोगे, कौन सा रेडियोलॉजिकल इन्वेस्टिगेशन करोगे? यस, गोल्ड स्टैंडर्ड इज CT सिस्टर्नोग्राफी. आई एग्री, 100% एग्री. अगर मैं ये भी कहता हूँ अगर PG एग्जाम में किसी बच्चे ने कुछ और बोला, he or she will fail. But if you read through the PJ Wormod, okay, they are saying if you are HRCT and your simple contrast MRI brain, you can detect more than 90% of your CSF leak. ठीक है. CT cysternography, why I am not against it. If you have facilities, do it. But very high chance of anaphylaxis. Gold standard है. But आप there is one more entity, MR cysternography. MR cysternography is a non-invasive cysternography. It's just a type of highly weighted MRI. Okay. T2 weighted, diffusion weighted MRI. मैं इसके अगेंस्ट नहीं हूँ, बट अगर आप जहाँ भी आप CT सिस्टर्नोग्राफी का भेज रहे हो, एवरी फैसिलिटी ऑफ, मतलब कि भैया एनाफाइलेक्सिस हो जाए, उनके पास एक रिसोसिटेशन के लिए ट्रॉली वगैरह सब है, डॉक्टर है, ऐसा होता नहीं है मैम. हाँ, CT सिस्टर्नोग्राफी दे विल डू इट बाय अ लंबर पंक्चर बाय अ न्यूरोलॉजिस्ट. You have to inject the dye or there is high chance. Better to get the MR cysternography patient can afford. ये मेरा इंडिविजुअल परसेप्शन है, मैं सबका अलग वेरी कर सकता हूँ. और चलो ठीक है, आपने इन्वेस्टिगेट कर लिया, फिर
कंजर्वेटिव मैनेजमेंट के लिए पहले सब दो हफ्ते
नहीं. देखिए मैं आपको एक बात बताता हूँ, कंजर्वेटिव मैनेजमेंट और ट्रॉमेटिक. ओके, बट मेरा पर्सनल एक्सपीरियंस क्या था, मैं पहले लोहिया में था, रामनोर लोहिया में. तो अगर पेशेंट करेगी MRI, मैंने क्यों बोला, इट्स नॉट मैटर ऑफ कि आप MRI आपको कराना है शौक है, नहीं. सम टाइम देयर इज हर्निएशन ऑफ मेनिंजेस और ब्रेन पैरेन्काइमा. इस मेनिंजोएन्सेफेलोपैथी इज देयर. आप कितना भी कंजर्वेटिव ट्रीटमेंट दे दो, कुछ ना होने वाली है ना, क्योंकि जब कोई चीज आपकी इंट्राक्रेनियस कैविटी से हर्निएट होकर आपके स्कल बेस से नीचे आ रहा है, आप कंजर्वेटिव ट्रीटमेंट करोगे ना, कुछ नहीं होगा. ट्रॉमेटिक CSF लीक यू हैव टू वेट टिल 10 days, है ना, 10 days तक आपको वेट करना है. ठीक. हर्निएशन है, there is no benefit by a conservative management. ठीक है, पेशेंट को टेम्परेरी आप लोअर डाउन फ्लेक्शन करोगे, थोड़े दिन के लिए रुक जाएगा. आप डायमॉक्स वगैरह कितने दिन दे दोगे? 10 डेज, 15 डेज, 1 मंथ, कितने दिन चला दिया? जैसे रोकेंगे, बिना इंट्राक्रैनियल हाइपरटेंशन है पेशेंट को, पेशेंट हैव टू गेट सर्जरी एट दैट टाइम. अगर कोई भी मेनिंजेस या मेनिंजियोसील या मेनिंजियोएन्सेफेलोसील अलॉन्ग विद सीएसएफ लीक है, पेशेंट हैव टू गेट सर्जरी. सर्जरी हमने प्लान कर दी. अब मेरा टॉपिक है एंडोस्कोपिक अप्रोच टू स्कल बेस. तो नाउ आई विल टेल अबाउट हाउ टू प्रोसीड विद द सीएसएफ रिपेयर. चलो, सीएसएफ रिपेयर हमने करना चालू किया. ठीक है, अब सीएसएफ हमने पेशेंट को जीए में लिया. नेवर ट्राई सीएसएफ रिपेयर इन एलए. ठीक है, क्योंकि यू हैव टू डू लॉट ऑफ थिंग इन द स्कल बेस. ठीक है, वाई? पेशेंट का जरा सा मूवमेंट हुआ, यू डोंट वांट टू इंक्रीज द स्कल बेस डिफेक्ट. पेशेंट जरा सा मूव कर गया, भैया स्कल बेस की म्यूकोसा को डिन्यूएट कर रहे थे. तो बेसिकली यू हैव टू क्या करना है, आपको जीए में लेना है, रॉ एरिया क्रिएट करना है, जितनी भी म्यूकोसा है हटाना है वहाँ से. म्यूकोसा हटाने के बाद यू हैव टू हार्वेस्ट सर्टेन टिश्यू, लाइक मोस्ट कॉमनली वी यूज टू टेक फेशियल आटा. ठीक है, फेशियल आटा को हार्वेस्ट करने के लिए सिंपल, वेरी सिंपल टू हार्वेस्ट. इट विल टेक मैक्सिमम 10 to 15 मिनट टू हार्वेस्ट द फेशियल आटा in thin patient. Obese patient have a lot of fat. Okay, तो फेशियल आटा हार्वेस्ट किया. उसके बाद आपने रॉ एरिया पूरा क्रिएट कर दिया. ठीक है, उसके बाद आपने क्या किया, आपने एक टी सील होता है, सर्टेन टाइप ऑफ ग्लू, फाइब्रिन ग्लू जिसको बोलते हैं, मार्केट में टी सील आता है. ठीक है, और सर्जी सेल का और फैट का उसको सैंडविच मॉडल में लगा के आपको पैक कर दिया. टी सील से आपने सील कर दिया. उसके बाद आपने उसको जो आपने पैकिंग की टी सील पे लगा दिया. Then you have to put certain gel foam so that you can support it, that part. Why gel foam is important? Reason is मेजर पैक आप लोग क्या डालते हैं, मैरोसिल है ना, मैरोसिल डालते हैं ना. आपने मैरोसिल निकाला, ऐसा ना हो जो आप जिसको आप चिपकाए हो सब पूरा एक बार में बाहर आ जाए. ठीक है, you have to support with your adjust. These are the things practically which I felt very important. ठीक है, जो मैंने किया वो मैं बोल रहा हूँ. बाकी सबका अलग अलग रहता है, सबके व्यू अलग होते हैं, सबके डीलिंग, पेशेंट डीलिंग अलग होती है. देयर इज नो हार्म, है ना, सबकी विचारधारा एक नहीं हो सकती. यही हर एक की इंडिविजुअलिटी है. वी शुड नॉट लूज अवर इंडिविजुअलिटी, बट वी शुड नॉट हार्म द पेशेंट आल्सो. जो करेक्ट है उसको फॉलो करना चाहिए, जो चीज़ गलत है उसको नहीं करना. चलो जी, सीएसएफ का आई थिंक मॉर्निंग सम लेक्चर आल्सो देना. Then I will not go for deeper CSF. Most common site is cibriform. The second most common site is lateral recess of the sphenoid sinus, है ना, स्टनबर्ग कैनाल इसको भी बोलते हैं. सर, मैं आपको एक प्रैक्टिकल चीज बताऊँ. टू टॉक टू डॉक्टर, अर्लियर पीपल यूज टू पुट अ कार्टिलेज. Okay, but I am telling you, cartilage will not cause a perfect seal. It will, because air is trapping between them. because आप cartilage को पूरा चिपका नहीं सकते हो. आप फैट वगैरह को पूरा टाइटली पैक कर सकते हो. कार्टिलेज के जितने शुरुआत में, जिससे अर्लियर इवन डॉक्टर सतीश जैन यूज्ड टू पुट अ कार्टिलेज अलॉट, बट नाउ ही स्टॉप इट. यू टॉक टू डॉक्टर रमनदीप विरम सर, पीजीआई चंडीगढ़, ही स्टिल है, professor. I talked to him one concern. He said I stopped cartilage several years back because आपका perfect seal नहीं बनता है. cartilage स्कल बेस आपका स्मूथ फर्श नहीं होता है कि आप cartilage की तरह कोई चिपका दें. इसे रफ करते. cartilage जब पहले यूज करते थे, जितने अधिकतर cartilage से जिनसे यूज होता था, सब में रिकरेंस होता ही. इसमें आपका 70% चांस हीलिंग का रहता है, 20-30% चांस रिकरेंस रहता है. बट अगर इफ यू यूज cartilage, it will not cause परफेक्ट सील. तो रीजन क्या है, कार्टिलेज का भी एक वेट होता है सर. ठीक है. सेकंड थिंग, अगर आपने कोई आपको मेनिंजियोएन्सेफेलोसील वगैरह है, आपको उसको अंदर नहीं घुसेड़ना है. आपने बॉल प्रोब लिया, उसको आपने अंदर करना चालू कर दिया. नो, दैट इज आल्सो रॉन्ग. दैट इज दैट ब्रेन टिश्यू. यू हैव टू कॉन्ट्राइज विद योर बाइपोलर कॉर्टरी. यू हैव टू रिमूव द म्यूकोसा, हाउ मच यू कैन रिमूव इट. अगर सपोज करो डिफेक्ट अगर 2 mm का है, उसके सराउंडिंग का आपका 1.5 सेंटीमीटर या 2 सेंटीमीटर का रॉ एरिया क्रिएट करना पड़ेगा. टिल दैट टाइम आई विल स्टार्ट समथिंग अ बेसिक एनाटॉमी. मोस्ट इंपॉर्टेंट थिंग, देखिए अब आपकी चीज एक आपने पढ़ ली, आप क्यूबिफॉर्म प्लेट पढ़ लिया, फ्रंटल साइनस पढ़ लिया, ठीक है जी. तीसरी इंपॉर्टेंट चीज आता है जो हम लोग फेस सर्जरी में ऑब्जर्व करते हैं, ऑर्बिटल इंजरी. सो हाउ विल यू प्रिवेंट ऑर्बिटल इंजरी? इट्स ए सिंपलर वे, ठीक है, वेरी सिंपल टू अवॉइड ऑर्बिटल इंजरी. सपोज आप अंसेक्टोमी कर रहे हैं, ठीक है. तीसरी इंपॉर्टेंट चीज, बेसिक स्टेप्स है, नेवर पुल एनी स्ट्रक्चर. दिस इज बेसिक थिंग. अगर आप फेस कर रहे हो, आपने अंसेक्टोमी की, देखिए लोअर एंड निकालना इजी है, हॉरिजॉन्टल पार्ट और अनसिनेट निकालना इजी है. यहाँ जैसे अपर पार्ट आता है, लोग क्या लेते हैं, ब्लैक स्लीव लेते हैं, उसको पुल करते हैं. नेवर डू. यूज द ट्रू कट फोर्स. ट्राई टू कट द अपर एंड. द सिंपलर वे टू अवॉइड ऑल दिस थिंग, इंजरी, ऑर्बिटल इंजरी और वॉट एवर स्कल बेस इंजरी. मैंने बोला ये सपोज करिए आपका मैक्सिलरी साइनस का ऑस्टियम आपने यहाँ खोल ली, ठीक है, ये आपका मिडिल टर्मिनेट यहाँ पर है, ठीक. सेकेंड थिंग है कि आपका अपर एंड वाला जो अंसनेट का जो पार्ट है, सपोज ये आपका अंसनेट है, आपने ये पूरा आपने अंसनेट हटा दिया, अपर एंड वाले को यूज द ट्रू कट एंड जस्ट कट इट. दिस इज योर लैमिना पेपरेसिया, ठीक है. सो नेवर गो लेटरली, ठीक है. वंस यू फाइंड द ऑस्टियम, उसके पैरेलल रहना है. इथमाइडेक्टोमी कर रहे हो, ऑलवेज टेक पैरेलल टू योर लेटरल वॉल. यू विल नेवर डैमेज द. अच्छा चलो, अगर डैमेज हो जाए, सबसे पहला साइन क्या मिलेगा? फैट विल प्रोलैप्स, ठीक है. यू विल डू द क्लिनिकली. आपका पहले फैट प्रोलैप्स हुआ, आप सबसे पहले आप कैसे चेक करोगे? यू विल प्रेस द आई. 70 साइन इसको बोलते हैं, बल प्रेस साइन. आल्सो बल प्रेस साइन. You just press it and you see it, the orbital fat is coming and going. So, what will you do? Leave it like that. You just pack your nose cavity. Don't keep that pack for more than 48 hours. You just remove it. अगर और लेमिना का डायसेंस हुई है, कुछ नहीं होगा पेशेंट until you poke your instrument through the fat, ठीक है. अधिकतर लोग क्या करते हैं सर, फैट को चेक करने के लिए ब्लैक स्लीव लिए, उसमें उसेल लिए और निकाला, पानी में डाल, सलाइन में डाल के देखते फ्लोट कर रहा है. देन यू कैन डैमेज मोर. सिंपल साइन है, वो फैट ही होगा, ऑर्बिट से फैट ही आएगा, है ना. एंड अगर होता भी है, कुछ नहीं होगा पेशेंट में. अगर फैट प्रोलैप्स हो गया, नथिंग विल हैपन. बट राइट, आवर एफर्ट शुड बी कि हम लोग को ऑर्बिटल इंजरी नहीं करनी है ना. लेमिना बहुत थिन पेपर लाइक बोन होता है. चलो जी, अब हमने चलो ये तो कर लिया. अब आता है कि किन केस में हमें इंजरी करना ही है, स्पेशली जब आपको ऑर्बिटल डिकम्प्रेशन करना है, ठीक है. सपोज ऑर्बिटल अगर डिकम्प्रेशन करना है, तो अब इसके इंडिकेशन क्या है? पेशेंट को आरटीए हुआ, एक बोनी चिप या कोई आरटीए हुआ जिसके कारण एक हेमाटोमा बना है, ऑप्थेल्मोलॉजिस्ट ने, और वो हेमाटोमा आपका प्रोग्रेसिवली इंक्रीज कर रहा है. अगर हेमाटोमा बनेगा तो क्या होगा? वाई पेशेंट विल लूज द विजन, क्योंकि ऑप्टिक नर्व उतनी ज़्यादा स्क्रैच होगी आपकी. देखिए ऑप्टिक नर्व ग्लोब है, तो पीछे ऑप्टिक नर्व जा रही है. हेमाटोमा बना तो ऑर्बिट एक्सोथैलेमस होगा, आगे की तरफ आएगी, ऑप्टिक नर्व स्क्रैच होगी, पेशेंट का विजन, ब्लरिंग और विजन होना चालू है. तो आपको क्या करना है? आपको प्रेशर रिलीज करना है, ठीक है. आप मोस्ट इम्पॉर्टेंट थिंग है कि अगर इमीडिएटली अगर ऑप्थेल्मोलॉजिस्ट है, दे कैन डू कैंथोटॉमी, ठीक है, लेटरल कैंथोटॉमी, और पेशेंट को आप ओटी में लें और आप लेमिना को कंप्लीटली रिमूव कर दें, ठीक. दूसरी चीज, सम टाइम आई हैव सीन वन पेशेंट व्हिच आई ऑपरेटेड इन 2022. देयर इज सर्टेन टाइम पीरियड. अब पेशेंट को एक्सोथेर्मोस है पिछले 1 मंथ से, आप सर्जरी कर रहे हो कि भैया हम आपका ऑर्बिटल डिकम्प्रेशन कर रहे हैं. नेवर रीएश्योर द पेशेंट कि आपका विजन वापस आएगा. अगर जितना टाइम ज़्यादा होता जा रहा है, द मोस्ट इम्पॉर्टेंट थिंग इज कि स्फिनॉइड बोन कैसे होते हैं, बटरफ्लाई शेप होती है, एवलोडी बोन, It has two wings, lesser wing and greater wing. Between these two wings, there is one fissure known as superior orbital fissure. Certain structure passes through superior orbital fissure. I will not go to deep. Then there are certain foramen like foramen rotundum and foramen spinuous and foramen ovale. These three foramens are there. Here you are seeing the optic canal through which optic nerve and ophthalmic artery comes, and here this is your sella tonsilica जिसमें आपका पिट्यूटरी लॉस करती है. ठीक है, पिट्यूटरी के आगे ये ऑप्टिक नर्व ऐसे आती है, ऑप्टिक क्याज्मा बनाती है, ऑप्टिक नर्व के फाइबर क्रॉस कर. ये हमारा बेसिक थिंग है. ठीक, स्फिनॉइड बोन के बारे में. स्फिनॉइड बोन में बॉडी होती है, टू विंग्स होते हैं. पोस्टीरियरली देखा जाए एक टेरिगॉइड बॉडी होती है जिसकी दो प्लेट्स होती है, मीडियल टेरिगॉइड प्लेट, लेटरल टेरिगॉइड प्लेट. मसल अटैच रहती है इससे टेरिगॉइड प्लेट से. ठीक है. नाउ अब इम्पोर्टेंट चीज़ है कि हमें इंटरनल कैरोटिड आर्टरी को समझना. ठीक है, स्कल बेस से अगर पढ़ना है तो थोड़ा बहुत इंटरनल कैरोटिड आर्टरी के बारे में, आपके रिलेशन के बारे में रफली हमको पता होना चाहिए. ठीक है. सो सपोज वी ड्रॉ two plates. This is your medial pterygoid plate. Suppose we draw two plates. This is your medial pterygoid plate and this is your lateral pterygoid plate. Okay. ठीक है. Now you draw this line here. Here you will see one foramen which will lead to one canal. Can anyone tell? Vidian canal. ठीक है. Vidian canal carry the nerve known as Vidian nerve, which is formed by the fusion of two nerves. One is greater superficial petrosal nerve and deep petrosal. ठीक है. इन दो के फ्यूजन से बनते हैं. Why I am bothering about Vidian canal? Because this is the landmark of internal carotid artery when we are doing skull base surgery. विडियन कैनाल के ऊपर 45 डिग्री पे एक नर्व पास होती है, विच नर्व V2, विच इज ए ब्रांच ऑफ ट्राइजेमिनल नर्व, मैक्सिलरी ब्रांच ऑफ ट्राइजेमिनल. ओके. नाउ अब मैंने बोला कि यहाँ से हमारा विडियन कैनाल है, ये एक आपका लैंडमार्क ले जाती है फॉर द इंटरनल कैरोटिड आर्टरी. ठीक है. सपोज यहाँ पर आपकी इंटरनल कैरोटिड आर्टरी ये जा रहा है. ये इंटरनल कैरोटिड आर्टरी का कौन सा पार्ट हुआ? पैराक्लाइवर. दिस इज योर पैराक्लाइवर इंटरनल कैरोटिड आर्टरी. गॉट इट. अब मेरा यहाँ पर ऊपर आता है आपका स्फिनॉइड साइनस. ठीक है. स्फिनॉइड साइनस के रूफ पर ये आपकी पिट्यूटरी ग्लैंड लॉज है, पिट्यूटरी ग्लैंड पीजी. स्फिनॉइड साइनस की लेटरल वॉल पे ये पैराक्लाइवर ऊपर जाएगी और बनाएगी पैरासेलर पार्ट ऑफ द इंटरनल कैरोटिड आर्टरी. So this is your, which is just adjacent to the pituitary gland is, which is paracellular, because this entity known as sella tonsilica. So this is your paracellular. किसी को डाउट हो प्लीज समझ लेना. I have taken minimum 1 month to understand this much concept. I talked with Dr. Muralidharan from Tamil Nadu. He told me this thing in simpler way. What I learned, I am telling. Then carotid artery, internal carotid artery, go like this, okay, and that thing is going to the carotid canal. So this part of carotid artery, internal carotid artery, known as intratemporal, which travel into the petrous apex. What is? So intratemporal part जो है उसके दो पार्ट हैं. वन इज हॉरिजॉन्टल, अनदर इज वर्टिकल. अल्टीमेटली थ्रू द कैरोटिड कैनाल ये आपकी पास हो. पैरासेलर, पैराक्लाइवर, इंट्राटेम्पोरल के दो पार्ट, हॉरिजॉन्टल, वर्टिकल. ठीक. अब हमारा आता है, चलो ये हमने बोला मीडियल टेरिगॉइड प्लेट, ये लेटरल टेरिगॉइड प्लेट. ठीक. ये आपकी बाउंड्री बनाती है कि किस चीज की? नेजोफेरिक्स की लेटरल बाउंड्री. समझ रहे हैं ना? मीडियल टेरिगॉइड प्लेट आपका क्या बनाएगा? नेजोफेरिक्स की लेटरल वॉल की तरफ जाएगा ना. ठीक है, इसके पीछे जो होगा यूएस स्टेशन ट्यूब ओपन होगी, मीडियल टेरिगॉइड प्लेट के पोस्टीरियरली आपकी जो ओपन होगी यूएस स्टेशन ट्यूब ओपन होगी। ठीक, अब ये मीडियल टेरिगॉइड प्लेट, अब आपका यहाँ पर सपोज करो ये एंटीरियर टॉन्सिलर पिलर, एक पोस्टीरियर टॉन्सिलर पिलर। ठीक, और यहाँ पर ये आपका बेस ऑफ द टंग। ठीक, अब आपकी कैरोटिड कैनाल से इंटरनल कैरोटिड आर्टरी आपकी फर्दर जो बनती है इसको बोलते हैं पैराफेरेंजियल पार्ट ऑफ द कैरोटिड आर्टरी। तो दिस पार्ट इज नोन एज पैराफेरेंजियल बिकॉज ये आपके फेरिंग्स के लिए कर। So this is paracellar, paraclival, इंट्राटेम्पोरल टू द फीटर टेम्पोरल बोन से होके जा रहा है, कैरोटिड कैनाल से जा रहा है, फिर आपका पैराफेरेंजियल आ रहा है। ओके, नाउ अब आपका क्या आता है, यहाँ पर अगर आपको एक चीज आपने पढ़ी होगी, ठीक है, यहाँ पर आपका अच्छा यहाँ पर एक आपका जुगुलर बल्ब और होता है ना, कैरोटिड के पीछे जुगुलर बल्ब और आपकी इंटरनल जुगुलर वेन साथ में जा रही है, गॉट इट। ठीक है, ये आपका कॉन्डाइलर प्रोसेस, ये आपका टीएमजे जॉइंट, टेम्पोरोमैंडिबुलर जॉइंट। यहाँ पर आपका स्टाइलर प्रोसेस हुआ, स्टाइलर प्रोसेस से 3 मसल्स सॉरी, ठीक है, वन इज स्टाइलो फेरेंजियल मसल जा रही है ये, देन स्टाइलो ग्लॉसस, देन टुवर्ड द हायोइड स्टाइलो हायोइड। पैरासेलर के कैरोटिड के पास एक आपका जाता है सुपीरियर ऑर्बिटल फिशर, जो कि आपका लेसर विंग और ग्रेटर विंग ऑफ स्फीनॉइड के बीच में। ठीक, इंपॉर्टेंटली ऑप्टिक नर्व इज नॉट ए कंपोनेंट ऑफ ऑर्बिटल फिशर, व्हिच ऑप्टिक नर्व ट्रेवल थ्रू द ऑप्टिक कैनाल। ठीक है, तो ऑप्टिक नर्व की आपकी ये आ रही है ऑप्टिक नर्व। ठीक है, ये सब आपका स्फीनॉइड साइनस की लेटरल, ये आपका स्फीनॉइड साइनस बनाया है ना, ये आप यहाँ इसके ऊपर आपका वो है क्वाना, ये आपका क्वाना है, ये आपका क्वाना का पोस्टीरियर पार्ट ऑफ सेप्टम है बीच का, ये आपका स्फीनॉइड साइनस ऊपर बनाया है, ये आपका ऑप्टिक नर्व। ऑप्टिक नर्व से अराउंड एक होता है रिंग, है ना, एनुलर रिंग होती है जिसमें आपकी सारी एक्स्ट्रा ऑक्युलर मसल्स के टेंडन इंसर्टेड होते हैं, एनुलर रिंग या जिन जिसको बोलते हैं। ठीक है, which divides the orbital fissure into 3 parts. ठीक, चलिए, so why I am telling these things, because आपको पता इंटरनल कैरोटिड आर्टरी का कोर्स स्कल बेस में समझना थोड़ा सा टिपिकल रहता है। हम लोग बोलते हैं कोई भी कॉन्सेप्ट में जाओ, व्हाट इज पैराक्लाइवल, व्हाट इज पैरासेलर, है ना, आदि चीजें आधे लोगों के सिर से ऊपर से जाती हैं। I took some time to understand that part, so it's a simpler way. My drawing is too bad, but that is okay. So important, if you are talking about do be a separate class of pictures, you know. It's not you have to do along with neurosurgeon. Most of the time neurosurgeon asks for ENT people to, so that they can feel they can find the field the posterior. You have to remove the, you have to cut the middle term rate, you have to remove the interfront sinus, nasal cavity के sinus को posterior septectomy करना है, फिर आप पूरा आपको आउल आई एफटीएच मिलता है इन द एंटीरियर वॉल ऑफ स्फीनॉइड साइनस, यू हैव टू ड्रिल इट। ठीक है, व्हाइल यू आर ड्रिलिंग यू हैव टू बी फोकस ऑन, यू हैव टू बी एट द सेंट्रल पार्ट, क्योंकि अगर आप लेटरली जाओगे तो आपको पैराक्लाइवल और पैरासेलर इंटरनल कैरोटिड आर्टरी के मिलने के चांस। सो दिस इज लाइक आई विल नॉट टच इट, तो दिस इज द हाइपोफाइजिक फोर्स वेयर द पिट्यूटरी लॉज। ठीक है, इसके एंटीरियर होता है ट्यूबरकुलम सेले, इसके एंटीरियर होता है ऑप्टिक यार्न, वेयर द ऑप्टिक नर्व कम्स। There are two processes, anterior clinoid process and posterior clinoid process. एक चीज मैंने जब CSF के बारे में बता रहा था, मैंने बोला था मोस्ट कॉमन साइट इज ट्यूब्यूल फ्रॉम प्लेट लेटरल एडमिट। समटाइम आपका CSF भी कम फ्रॉम द लेटरल वॉल ऑफ द स्फीनॉइड व्हेन द आपका टेरिगॉइड बॉडी हाइपरनिमेटाइज हो कैनाल ऑफ चैम्बर लेटरल रिसेस से जो लीक होता है ना, वो आपका रहता है। एंड स्कल बेस में अब आपका एक एंटिटी बचती है इंफ्राटेम्पोरल फोसा। ठीक, तो इंफ्राटेम्पोरल फोसा की अगर बात करें वेयर इट लाइज, हियर आई कैन टेल यू बट द डायग्राम नॉट सो क्लियर। सो इंफ्राटेम्पोरल फोसा, यू हैव टू, इफ यू वांट टू अंडरस्टैंड द इंफ्राटेम्पोरल फोसा यू हैव टू सी द स्कल फ्रॉम द बॉटम। ओके, सपोज दिस इज योर मीडियल टेरिगॉइड प्लेट, दिस इज योर लेटरल plate, this is the lateral pterygoid plate. Okay, these are the posterior layers one. Okay, this is your styloid process, this is the Zygomatic. Okay, and this is your maxillary. Now, infratemporal fossa, where it lies? It lies lateral to the medial pterygoid plate. That is the medial border of the infratemporal fossa. Lateral border is your zygomatic. See, this diagram is important. See how the olfactory nerve comes to the complete area. So just like chalni se nerve aa rahe hain. You see, the sixth part is your infratemporal fossa. Sixth number is your infratemporal fossa. Laterally zygomatic process, and this is your pterygoid plate. अच्छा एक चीज इम्पोर्टेंट मैं और बता दूं कि इंफ्राटेम्पोरल फोसा मेजर कैविटी से कैसे रिलेटेड है. सिंपल डायग्राम में अगर हम बात करें, सपोज दिस इज योर नेजल कैविटी. तो नेजल कैविटी और यहाँ पर आपका क्या होगा, मैक्सिलरी साइनस. गॉट इट. मैक्सिलरी साइनस के पीछे क्या होगा, टेरिगोपैलेटाइन फोसा. टेरिगोपैलेटाइन फोसा मैक्सिलरी साइनस की पोस्टीरियर वाल के पीछे. ठीक. अब टेरिगोपैलेटाइन फोसा कम्युनिकेट विद नेजल कैविटी थ्रू द स्फीनोपैलेटाइन फोरामेन. ओके, so this is maxillary sinus, this is pterygopalatine PP fossa. Now this sphenopalatine foramen communicate with the infratemporal fossa, okay, with the help of pterygomaxillary fissure. So here is pterygomaxillary fissure. So nasal cavity communicate with the pterygopalatine fossa with the help of sphenopalatine foramen, through which sphenopalatine artery comes, which is the major supply of the nasal cavity. Sometimes you have to ligate and cauterize the sphenopalatine artery. Okay, which is the sphenopalatine artery is a branch of internal maxillary artery. See, internal maxillary artery travel in the pterygopalatine fossa and infratemporal fossa. That's the content. See, then pterygopalatine fossa communicate with the infratemporal fossa with the help of pterygomaxillary fissure. Okay, how will you approach the pterygopalatine fossa transnasally? They are for infratemporal fossa transnasally or endoscopy. So basically there are several ways to reach the infratemporal fossa. One is anterior approach, another is lateral approach. Okay, lateral approach was given by Fitz, type A, type B, type C. Okay, so type A, when the tumor is very limited, okay, up to the petrous apex, you can do it with type A. Type B, when it involves the carotid, internal carotid artery also. Type C is when it involves the petrous apex, extensive part of infratemporal fossa, everything. That is type C. So, but today's topic is not by Swiss approach, my topic is by transnasal, endoscopic approach. So how will you reach? What you have to do is, anybody remember that term modified ankle? Medial maxillary. So what we are doing is, we are removing the medial wall of maxillary sinus or some part of anterior wall. है ना? कितनी anterior wall? maxillary sinus के anteriorly क्या होता है? Infraorbital foramen, which have infraorbital nerve. That's a laterally how much we can go? You should not go beyond the infraorbital foramen. ठीक है? So you are removing the some part of medial wall and some part of anterior wall of maxillary sinus. Anterior wall का थोड़ा part कितना? Up to infraorbital foramen. That is the lateral most limit of medial maxillary. We remove this part. वाइड एंसेनेक्टोमी हो ऑलरेडी कर दिया है. लिटिल बिट एंटीरियर वॉल मैक्सिलरी साइनस हमने हटा दिया है. उसके बाद यू ग्रेजुअली यू रिमूव द पोस्टीरियर वॉल ऑफ मैक्सिलरी साइनस टू द जे क्यूरेट. अब जे क्यूरेट को करें धीमे धीमे से उसको हटा. समटाइम यू विल सी द फैट इज कमिंग आउट, बट यू हैव टू बी केयरफुल. द इंटरनल मैक्सिलरी आर्टरी विच ट्रेवल टू द टेरिगोपैलेटाइन फोसा, स्फीनोपैलेटाइन की जो मतलब स्फीनोपैलेटाइन आर्टरी अराइजेस फ्रॉम द इंटरनल मैक्सिलरी आर्टरी. तो इंटरनल मैक्सिलरी आर्टरी की ब्रांचेस समटाइम्स या टेरिगॉइड वीनस प्लेक्सस से आल्सो देयर. If venous bleed, that is not an issue. Internal maxillary artery, yes, it's a big issue. You should not damage the internal maxillary artery. पहले आप उसको तोड़े तो फ्लिप कर बेटर, ठीक है. ठीक, you remove the posterior wall of maxillary sinus completely, then you are in the infratemporal fossa. Some tumor, especially JMA, which arises from the this area, sphenopalatine, earlier thodi arises from the sphenopalatine foramen, but this is no more now. Mainly it arises from the median canal, pterygoid body, medial or lateral pterygoid plate. Also sphenopalatine foramen. Okay. Sometimes if DNA goes up to infratemporal fossa, then you can remove this approach. But the tumor limited to infratemporal fossa and reaches up to the ramus or lateral limit is zygomatic process. Zygomatic process is the lateral limit of the infratemporal fossa. अगर वहाँ तक ट्यूमर जा रहा है, you cannot remove by endoscopy. You have to do the combined approach, which is by the lateral approach plus endoscopy. Okay. By this, I'm going to finish it.
Endoscopic anatomy of skull base. So the boundaries of the skull base. The anterior boundary is the upper incisor teeth. The posterior boundary is the superior nuchal line. The lateral boundary, except the incisors, all other upper teeth and the zygomatic arch. Now the skull base is divided into three parts: the anterior skull base, the posterior skull base, the middle or the lateral skull base. So the anterior skull base, it forms the floor of the anterior cranial fossa and the roof over the orbits and ethmoid bone. It is formed by the frontal bone, the cribriform plate of the ethmoid bone, and lesser wing and body of the sphenoid. So the parts, now first the ethmoid bone, the parts of the ethmoid bone. The ethmoid bone is formed by the central perpendicular plate, the cribriform plate, and the paired labyrinths. The midline perpendicular plate forms the central superior part of the nasal septum, articulating with the quadrilateral cartilage and posteriorly articulating with the vomer. The labyrinths, containing numerous air cells, they lie medial to the orbit and form part of the lateral wall of the nose. They are anterior to the body of the sphenoid. They occupy much of the upper part of the maxillary hiatus. The lamina peperacea is a paper-thin orbital plate of the ethmoid which separates the ethmoid sinuses from the orbital cavity. Now the two important structures in this region, the first one is the anterior ethmoidal artery. It is found 24 mm posterior to the anterior lacrimal crest on the frontal process of the maxilla. It arises from the anterior ethmoidal. The anterior ethmoidal foramina transmits the anterior ethmoidal artery. The second structure is the posterior ethmoidal artery. It is 12 mm behind the posterior ethmoidal. It is 12 mm behind. This is the posterior ethmoidal foramina. And 6 mm behind the posterior ethmoidal artery lies the optic nerve. So 24 mm posterior to the anterior lacrimal crest is the anterior ethmoidal artery. 12 mm posterior to it is the posterior ethmoidal artery, and 6 mm posterior to it is the optic nerve. Now the sphenopalatine foramen. It is found at the top of the perpendicular plate of palatine bone, posterior to the maxillary hiatus. It transmits the sphenopalatine artery. Posterior to the inferior concha, the eustachian tube orifice marks the medial end of the cartilaginous portion, which is found behind which is found the fossa of Rosenmuller. Now the muscles, the salpingopharyngeus muscle, it arises from the posterior aspect of the tubal orifice, and on contraction, it opens the eustachian tube. Now there are a pair of sphenoid sinuses which vary greatly in size, separated by a septum, which is usually not in midline. The sinus lies in front of the pituitary fossa, and when large, they may extend behind the posteriorly to the fossa also. Now the anterior approach, endoscopic endonasal approaches to the anterior skull base are used for lesions in the following places. Like if we want to approach the frontal sinus, if we want to approach the cribriform plate, the olfactory bulbs, frontal lobe, ethmoid roof, sphenoid sinus, pituitary gland, suprasellar region, cavernous sinus, and midclavian regions. Next we come to the posterior skull base. So the posterior skull base forms the base of the posterior cranial fossa and is formed by the occipital bone. Foramen magnum is present in the posterior skull base. The important landmark in posterior skull base is the cerebropontine angle. So the angle is bounded anteriorly by the sixth cranial nerve and lateral aspect of clivus, laterally by medial aspect of petrosa, medially by middle cerebellar peduncle, pons and ventral surface of cerebellum, superiorly by fifth cranial nerve, inferiorly by cranial nerves 9, 10, 11 and posteriorly by the cerebellar floccules. So what is in this region, the cerebropontine angle? There are cranial nerves 7 and 8, anterior inferior cerebellar artery, internal auditory canal. Separating the nasopharynx from the P-vertebral region is the pharyngobasilar fascia. Regions which can be accessed to the approach to the posterior skull base are occipital bone, sigmoid sinus, posterior cranial fossa, foramen magnum, and the upper cervical spine. Next, we come to the lateral skull base. The lateral skull base covers the remaining base of the skull between the anterior and the posterior skull base. It is bordered anteriorly by the anterior border sphenoid, together with the greater wings, the zygomatic arch, the posterior border of occipital bone. Laterally, it is made up of squamous and petrous parts of the temporal bone. The anterior aspect of the lateral skull base is made up from the body, posterior border and lesser wings and greater wings of the sphenoid and the medial and lateral pterygoid plates. So laterally it is formed by the zygomatic arch, posteriorly and medially by the sphenoid bone and lateral and medial pterygoid plates. Now the temporal bone. Temporal bone is divided either into 4 parts or some people say it is divided into 5 parts. The squamous part, the petrous part, mastoid part, tympanic part and styloid parts. The squamous part is the largest, forming the convex lateral surface aspect of the temporal fossa. Articulates anteriorly by greater wing of sphenoid, posterior superiorly with parietal bone. The zygomatic process of temporal bone originates anteriorly, below which is the mandibular fossa. Behind this, the squamous part forms the anterior part of the external ear canal. Medially, the squamous part joins the petrous part together with the mastoid part. It is collectively called the petromastoid part. The petrous part of temporal bone is full adult in size at birth. However, the mastoid part is absent, leaving the stylomastoid foramen near the lateral surface of the skull, covered only by thin fibers of sternocleidomastoid. So, the extracranial facial nerve is very superficial and vulnerable in neonates. As the sternocleidomastoid grows, it draws down and thereby develops the mastoid process. Mastoid process is palpable in the second year of life. Therefore, it protects the extracranial part of the facial nerve. The mastoid part is filled with varying degree of air cells. The sigmoid sinus deeply grooving its inner surface. Several important landmarks can be found on the superior surface of the temporal bone. The tegment tympani running along the posterior surface of petrous ridge is found the groove for the superior petrosal sinus. Between the two, the posteromedial to tegment tympani, a curved prominence, the arcuate eminence. It is made by the underlying superior semicircular canal. Just anteromedial to this is found the hiatus and groove for greater petrosal nerve and the groove for lesser petrosal nerve. The posterior aspect of petrous bone is perforated by internal auditory meatus. Medial to the base of styloid process, the petrous bone is hollowed to form the jugular fossa, which is divided into 3 compartments by 2 transverse septa of fibrous dura. This transmits the jugular vein in the posterior compartment. Middle compartment is shared by the vagus nerve and cranial root of accessory nerve, 11th nerve. The glossopharyngeal nerve and inferior petrosal sinus occupy the anterior compartment of the jugular fossa. The internal carotid artery enters the skull base through the carotid canal just anterior to the jugular foramen, separated from it from a wedge of bone. The tympanic part of the temporal bone lies lateral to the petrous bone, its lateral border ending at the cartilaginous part of external auditory canal. Its posterior superior surface is concave, forming the anterior floor and part of posterior wall of the bony ear canal. Arising from the inferior aspect, from the fusion of tympanic and petrous bones, the styloid process of the temporal bone projects downwards and forwards, giving attachment to several ligaments and muscles. The muscles attached are stylopharyngeus, stylohyoid and styloglossus. Four muscles lie lateral to the base of skull, the lateral base of skull, which are masseter, temporalis, sternomastoid and digastric. The lateral skull base approach is used for middle ear, mastoid and associated structures, sigmoid sinus, middle cranial fossa, parotid gland, facial nerve, cochlea, infratemporal fossa, eustachian tube, basis sphenoid and nasopharynx. Thank you.
Myself dealing with the pathology of the skull base. As we all know that skull base tumors form a highly heterogeneous group, and a large number of primary malignancy as well as secondary malignancies can develop in this area. Now the symptoms produced by any skull base lesion is determined by its anatomical location. For example, the anterior skull base lesion produces hyposmia, diplopia, headache, blindness and frontal headaches. If we are coming to the central lateral skull base lesion, they mostly presents with the headaches, diplopia. And if we are dealing with the lateral skull base, posterior skull base lesion, they are mostly dealing with the deafness and tinnitus. So there is a classification which is dealing with the common tumors of the skull base, that is anterior skull base, central skull base and lateral skull base. In anterior skull base, we have the common lesions, for example, mucoceles, inverted papilloma, angiofibroma, olfactory neuroblastoma, nasopharyngeal carcinoma, and lymphoma. Coming to the central skull base lesion, that is pituitary tumors, neuroma, chordoma, chondrosarcoma, plasmacytoma, fibrous dysplasia, and metastasis. Coming to the lateral skull base lesion, they are dealing with vestibular schwannoma, meningioma, neuroma, cholesteatoma, paraganglioma, metastasis, and squamous cell carcinoma. Now this classification deals only with the tumors of the anterior, middle and posterior cranial fossa. For example, anterior cranial fossa, we have primary and secondary tumors, asthenoreuroblastoma, chordoma, chondrosarcoma. These all tumors are dealing with the tissues that are involved. For example, if the soft tissue is involved, neural tissue is involved, fat is involved, blood vessels are involved, so tumors are dealing like this. Lymphoma, plasmacytoma, malignant melanoma, pituitary gland tumors, craniopharyngioma, lipoma, hemangioma, neurolemoma. In middle cranial fossa, same like this. Which is the most common tumor among all the lateral skull base, So the definition deals with, it's a malignant epithelial tumor with squamous cell differentiation. Now the common sites are temporal bone, gnathic bones, larynx, oropharynx, sinonasal tract and salivary gland. Coming to the morphological picture, they are mostly categorized as squamous keratinized, squamous non-keratinized, basaloid and adenosquamous carcinomas. Now if I deal with the immunostaining, they are mostly found positive for the P16, and if we come to the differential diagnosis for the squamous cell carcinoma, these are sarcomas, myofibroblastic tumors. Another is nasopharyngeal carcinoma. It is a carcinoma developing in the nasopharyngeal mucosa, which features exactly same as the squamous cell carcinoma. The specific point related to nasopharyngeal carcinoma is that the peak incidence is in the 5th and 6th decades with a twofold male predominance, and the risk of tumor development increases with the incidence of EBV Epstein-Barr virus infection. Next is craniopharyngioma. The definition is a benign tumor developing from the Rathke's pouch. The histological types include adamantomatous and papillary type and mixed subtype. Coming to the salivary gland tumors, now they can be benign as well as malignant forms. The most common is adenoid cystic carcinoma. Now it is also known as cylindroma. Primary tumors can develop within the salivary glands or less commonly in the mucosa of upper respiratory tract, including nose and sinuses. most commonly found in the 5th and 6th decades. The most common variants macroscopically as well as microscopically are solid, fibriform, tubular and mixed pattern. Now the next topic is soft tissue bone and cartilage tumor. As the name suggests, hemangioma. So the tumor is arising from the endothelium of the blood vessels. Now it can be of two types, capillary type and cavernous types. Lipoma, similarly arising from the mature fat. It's also of two types, benign and malignant. Benign are mostly circumscribed and encapsulated, and the malignant ones are grey, white, pale pink and myxoid in nature. Chondroma, arising from the differentiation towards the cartilage cells. Chondrosarcoma, it is a malignant soft tissue tumor which is the third most common primary tumor. Such tumor develop from the skull base, nasal septum or the gnathic bones. Rhabdomyosarcoma, it's a malignant tumor of the so-called soft tissue mesenchymal origin with skeletal muscle differentiation. It can be of three variants, embryonal, alveolar and pleomorphic types. The important tumor, that is inverted papilloma. It is a tumor of non-olfactory mucosa of nose, Schneiderian membrane and paranasal sinuses. It's also known as Ringer's tumor, transitional cell papilloma and lateral wall papilloma. Coming to the next one, juvenile nasopharyngeal angiofibroma. Coming to definition, it's a benign, uncapsulated, biologically progressive, highly vascular, with high incidence of persistence and recurrence, with vascular and fibrous component. It is also called as nasopharyngeal fibroma. Now the remarking feature is unprovoked spontaneous bleeding in adolescent male. It usually presents with such history. Others have connected to JNO to a hormonal influence affecting the proliferation of vascular erectile tissue following repeated microhemorrhages and repair. Coming to the pathophysiology, nasopharyngeal angiofibroma characteristically demonstrate angiogenesis and vascular proliferation situated within the posterior nasal cavity, sphenopalatine foramen and nasopharynx. They are non-encapsulated, well-circumscribed polypoid masses made up of both vascular and fibrous stromal tissue. Now the last topic, that is the central peripheral nervous system tumors. It includes glial tumors, which are mostly astrocytic neoplasms, ependiomas and oligodendrogliomas. Second one is astheneoneuroblastoma, also known as olfactory neuroblastoma, which is characterized by Homer-Wright pseudo-rosettes as well as flexural wintersina. It's a pathological finding. Meningioma, it's a benign tumor composed of meningoendothelial cells. Neurinema, benign tumor composed of differentiate neoplastic Schwann cells, also called as schwannoma. Paraganglioma, it's a tumor developed from the paraganglia outside the adrenals. They develop along the structures of paravertebral sympathetic and parasympathetic chains. Now coming to hematopoietic tumors. Number one is lymphomas, which arises from the mucosa of the nose and sinuses. Second one is plasmacytoma, arise from the monoclonal growth of the plasma cells. Now the miscellaneous or composed origin tumors. Tumors of pituitary gland. A functional approach to the pituitary gland divides it into anterior and posterior pituitary. In the former, it is responsible for the hormonal production. We might encounter the development of adenoma, carcinoma or oncocytoma. But in the latter, it is formed by evagination of the central nervous system. Such tumors are gangliocytoma, astrocytoma. The most common tumor of anterior pituitary is prolactinoma. Next is growth hormone secreting adenoma. It's a tumor developing in the pituitary gland which is composed of growth hormone producing cells. Malignant melanoma, it is derived from the melanocytic cells or their precursors. Primary tumors are found in the skull base apart from arising in the skin, usually develop in mucosal membranes. Teratoma, it's a tumor derived from the germinal cell with features of differentiation.
Actually, this topic nasopharynx, ये आपका topic Dr. Sumit sir लेंगे already. But just because I've written this, we'll just brush up with everything. So we all know what is nasopharynx, and we all have an idea. Most of सबसे ज़्यादा commonly, if I say, and if I'm not wrong, please ask मेरे seniors and colleagues, but you know, most common thing which you'll be seeing in your OPDs will be adenoids in the pediatric patients, if I'm not wrong. Sorry, sir. So we all know what is a nasopharynx. एक brief बता दे रही हूँ. It's just like a roof. It has got a floor. It has got a roof. दो lateral walls हैं, आगे पीछे interior posterior walls हैं. because it lies just behind the nasal cavity, तो जो posterior boundary of the nasal cavity है, that forms the anterior boundary of the nasopharynx, and that will be the posterior part of the nasal septum as well as the posterior coronus. That's it. And then if we go to the roof part, so the mucus, which is basically mucosal membrane, which covers the sphenoid, body of the sphenoid, basisphenoid and basiocciput, that forms the roof of the nasopharynx. And if I talk about the floor, तो इसकी कोई floor है नहीं, because it communicates with the posterior pharynx. So and then anterior roof हो गया, posterior, and laterally. So laterally we have got eustachian tubes, torus tuberous, J shape का inverted होता है, we all know. There is nothing new in this, which I should tell you guys because you people know everything about it. Now the contents, if we talk about, it has got adenoids. There are a couple of diseases which we see in our common practice. One more thing I would like to tell about is the embryology, which we people, as in ENT people, we don't deal with and we don't discuss this very prominently, because embryology is something which we think the anatomy people should discuss. So in the embryology part, there is no exact theory, or nobody exactly knows how it is derived, from which part it is derived, and किस part से ये बना हुआ है, nobody knows. But there are two concepts. पहला ये है कि torus tuberous, which if I'm not wrong, tubotympanic recess. So tubotympanic recess is formed from the first and second pharyngeal pouch. It is derived from that. And जो anterior या foremost part of the tubotympanic recess होता है, that forms the eustachian tube, and eustachian tube forms the lateral part of the nasopharynx. So we say it is derived from that also. This is one concept, and the second concept is that it is derived from the primitive nasal cavity. There are only two hypotheses which I have come across, and please sir, ma'am, अगर आप लोग में से किसी को भी पता हो तो let's discuss this. From there nasopharynx is derived, because till now in my complete PG and in my complete fellowships and everything, nobody has answered me this, from which part nasopharynx is derived. With nasal cavity, with oral cavity, and with our middle ear. So with the nasal cavity, it is connected with the posterior coronus, then with the oral cavity by the pharynx, and from the middle ear eustachian tube, and the most commonly we see is बच्चों में दिखता है सर ASOM and when we have muscles and all, I'll just go through with this. So it has got an outer circular layer and an inner longitudinal layer. Outer circular layer is composed of superior, middle and inferior constrictors, whereas the inner longitudinal layer is composed of stylopharynges, salpingopharynges and palatopharynges. That's all. One more thing, there is Waldeyer's ring, which is a very important part of the human body, and Waldeyer's ring का एक component is present in the nasopharynx, and that is the adenoids, again, which we will be discussing later. Now, bones of the nasopharynx, medially it is bounded by palatine, vomer, sphenoid and occipital bones, and laterally it is bounded by pterygoid process, sphenoidal, occipital and temporal bones. Then arterial and venous drainages. Arterial supply is by the ascending palatine artery, ascending pharyngeal artery, ascending cervical artery and maxillary artery, whereas venous drainage is by the submucosal plexus of veins, which further communicates with the pharyngeal plexus. Then nerve supply, motor, sensory and autonomic nerve supplies are present in the nasopharynx, and they are formed by the glossopharyngeal nerves, vagus nerve and sympathetic change. Histology, skip. Okay. Now, as one of my teacher explained me, आप कोई भी organ पढ़िए, there are only two types of diseases. One is your congenital disease, and another is your acquired disease. Now, you can have this is I'm talking about benign lesions. Okay. So basically, if you follow me or if I am, so I'll be telling you, there are only two types of diseases in any organ of the body, that is benign and malignant. Under benign, we have two categories. One is your congenital disorders, the another is your acquired or infective disorders. So for congenital conditions, the first one is transsphenoidal meningoencephalocele, except one point that it is very rare, found in 1 in 7 lakh babies, and it is of two types. One is intrasphenoidal and the another one is true transsphenoidal. So intrasphenoidal, as the name suggests, it is the meninges and the brain matter which will be herniating, that will be present only in the sphenoid sinus. Whereas the second one, that is true transsphenoidal, in that meningoencephalocele transverses the roof of the floor of the sphenoid sinus, and that forms the true transsphenoidal. Now, the most common presentation will be CSF rhinorrhea. One thing in this is, in the morning, both of the speakers, whether it was Dr. Tejasvi or Dr. Charunal, both of them had talked about Sternberg's canal. Sternberg's canal only holds importance in this condition. And there is one theory which ma'am very briefly told us, that there is an ongoing debate about Sternberg's canal. Now the Sternberg's canal, the earlier hypothesis was that it is present in almost every individual and it is an anatomical structure. But now the current concept is that it is because of age-related erosion. Now my question to everyone and maybe to the researchers will be, if it is present in everyone or if it is due to age-old destruction of the bone, then why is it occurring in the children? Because children are quite small, or transsphenoidal meningoencephalocele occurs in less than 5 years of age. So within 5 years of age, I don't think so. That is a limited time period, very short duration. I don't think so कि उतने में a child का the bone will go under erosion and will form the Sternberg's canal. So, but yes, the work is going on it. Now that case pouch, ma'am had explained. These are the things which we will not encounter. We will not encounter very frequently in our day-to-day practice. But just for the namesake, rat case pouch, I've only seen till now, till date, I've seen only one case of rat case pouch. At that time, I was doing my fellowship in head and neck surgery, but then we referred the patient to neurosurgeons and they only operated. But in this, it was a very small boy of, I think, 3 years. And that boy presented with CSF rhinorrhea. So that patient was, but obviously referred to them, and also because it has got pituitary gland tissue, and we as ENT practitioners do not very frequently operate pituitary gland. So that was operated by neurosurgeon people. The next one is congenital glioma. Nasopharyngeal glioma is a rare finding. It is marked with the presence of heterotrophic neural tissue within the nasopharynx. And then we have branchial cyst of nasopharynx. It is also a very rare thing. Most commonly transpalatal or endoscopic approaches are done. These are very rare. Then comes the nasopharyngeal dermoid, which is also known as hairy polyp. It is known as hairy polyp because it is covered microscopically. If we see the sections of the dermoid, then we will see that it is surrounded by skin. And skin has got the hair follicles. And in some of the cases, some case studies have reported that even the hair follicles along with the muscle and the teeth part was also present into it. Now we come to acquired conditions. In acquired conditions, we have adenoid hypertrophy. And for adenoid hypertrophy, the most frequently we ask is for X-ray nasopharynx. And this here is basically the adenoid hypertrophy which is present, and it's a 4-year-old boy whose X-ray is there. Now adenoid hypertrophy, so basically adenoid hypertrophy, if we discuss the bacteriological part, it is most commonly because of strep pneumonia and the viruses. Then most commonly, sir, if I'm wrong, do you think we should operate or should we wait for 14 years? Because we all know adenoid subsides by 14 years, 15 years. As the child progresses, there are chances that adenoid hypertrophy will go under reduction. So what do you think, sir?
We can give a track of 4 to 6 weeks.
Okay.
और फिर सिम्टोमेटिक बेस पर दोबारा आपका एंडोस्कोपी करके लेजर एंडोस्कोपी कितना एरिया इन्वॉल्व है मोर देन 75 इवन आफ्टर 30 और मोर देन 60% यू हैव टू ऑपरेट.
ओके. हाँ मैम.
With respect to the size factor, if the ears are involved, ear pathology is happening, then we will be doing, then we should do or put the child on follow-up. And if sometimes there is bleeding, it is not subsiding by any treatment, then we can do. And there is significant respiratory obstruction, snoring, etc. and this adenoid facies, to avoid that we can.
I have seen what people have taught me in Lohia is that you should, apart if the child is having snoring problems or as ma'am said middle ear problems, ma'am said speech problems, apart that if the child is highly symptomatic, then though we will operate that child. But what they taught me is, or what I follow is, you should wait. If there is chance that the child might undergo regression, so you should wait for at least for 6 months. Just observe the child, and if the child is showing, you can do frequent X-rays, you can do DNEs for that child, and if the child is showing chances or signs of regression, you should wait. And then if the child is symptomatic, no doubt you have to operate. There is no other way. Okay, now one more thing. One more thing is nasopharyngeal tuberculosis, which very frequently we see, but we don't diagnose it because either there are two problems. First of all, most of the tuberculosis patients are generally seen with the lymph nodes and maybe with the epistaxis and all. So in first attempt, you will not think of tuberculosis. But according to my experience, or maybe because I'm posted in a TB hospital, I don't know, I have seen a lot of nasopharyngeal tuberculosis patients. And as an ENT surgeon, it is very cumbersome for us to do a endoscopy for a TB patient. Because we all know, हमारे यहाँ एंडोस्कोप एक सेट होता है, फिर उसको क्लीन करना, उसको वो आपके पास स्टाफ नहीं होता है, वो थोड़ा सा cumbersome होता है. But nasopharyngeal tuberculosis is least reported but very frequently encountered. This is one thing which I see. So nothing much has to be done. You just have to diagnose it. आप biopsy कर सकते हैं, send it for gene expert, or for you can take the nasal swabs, send it for CBNAT, and then you can start on APT. That is the only thing which. तो जो nasal cavity से जो कुछ भी secretion आ रहा है, that you can collect और आप वो भेज सकते हैं. Sometimes मैम एक बहुत common सा चीज़ है which I have faced. Lucknow is divided into various zones. And they ask कि ATT जो है आपको अपने घर के पास वाले ही सेंटर से मिलेगी, वो आपको उस हॉस्पिटल में नहीं देने देते जहाँ पे आपने डायग्नोसिस की है. एंड द अदर पर्सन देयर हु सिटिंग, ही विल टेल कि ऐसा कुछ नहीं होता, हमारे यहाँ से दवाई नहीं मिलती. हाँ, होना चाहिए, एंड दैट्स इट, एंड वी डू इट. तो मीन्स आई एम डूइंग इट, इट्स नॉट लाइक कि दैट इज वन थिंग. There is one thing, आप टीबी के पेशेंट्स का एंडोस्कोपी करना, उनका ट्रिकियोस्टमी करना मना कर सकते हैं. दिस आई डिड नॉट न्यू, बट मेरे CMS सर ने भी मुझे बताया कि इफ यू आर नॉट फीलिंग कंफर्टेबल एंड इफ नाउ कम्स इज nasopharyngeal angiophygroma. हाँ सर, nasopharyngeal ट्यूबर पेशेंट विल प्रेजेंट विद lymph nodes. वन थिंग. दूसरी चीज़ उनको जो है ना सीवियर lymph nodes. दूसरी चीज़ सर उनको बार बार वो फीवर, जो नॉर्मल ट्यूबरक्लोसिस के सिम्टम्स होते हैं वो सारे सिम्टम्स होते हैं. अपार्ट दैट देयर इज प्रेजेंस ऑफ lymph node. Sometimes patient will present with epistaxis, and in few cases sir, in very few cases, like this was reported in one of the paper, I have not seen this case, but there was presence of CSF rhinorrhea also. Now I don't know the reason why it was, but it was there. So these are the two things. वैसे भी सर नेजो अगर आपको सस्पेक्ट कर रहे हैं एपिस्टैक्सिस के साथ lymph node, you will do a DNA because you want to rule out nasopharyngeal this thing carcinomas. So आप करेंगे एंड अगर rat bitten टाइप का अगर आपको म्यूकोजा वगैरह दिख रहा है, you know कि हाँ it is a tuberculosis thing क्योंकि and the moment you know it's a tuberculosis, it's not a carcinoma. So the whole treatment line changes. So now comes this nasopharyngeal angiofibroma. Most common, it is seen in males less than 14 years of age. Now there are people who tell that there is a role of progesterone and testosterone in the formation of nasopharyngeal fibroma. I don't think so there is. But हाँ ठीक है, whatever is reported, it's there. So nasopharyngeal angiofibroma, you all know how it presents and what all palsies and everything. We know everything about it. So there are 3 classifications regardingly. आप सब कोई follow करते होंगे. What I follow is basically Ratkowski's. Now, one thing, nasopharyngeal carcinoma, we all know it's radiotherapy, has to be done for it. But there are some surgeons, especially surgical oncology people, who tell you to operate about it. And there was a discussion regarding this because I had done my fellowship under surgical oncology HOD, so he was like, "No, we should operate, small carcinomas can be operated, but the best thing is radiotherapy."
So I'll start with the introduction. First of all, why there is a need for endoscopic approach to skull base? Because it provides, initially started with resection, endoscopic resection of pituitary tumors, then to the lesions of clivus, olfactory cleft, plenum, sphenoidal and petrous apex. The major advantage of endoscopic endonasal approach is that it provides direct anatomical approach access to the intracranial and paranasal sinus lesions, and it avoids the sequelae of skin lesion, craniotomy and brain retraction. But the major criticism is that it does not allow en bloc resection of the tumors, and further endonasal approach often allows resection without damaging adjacent healthy tissues, which is not the case with the conventional open surgeries, in which skin, bone and sometimes dura mater are opened to provide access to the tumor with risk of tumor seeding. Now talking about history, initially Sir Victor Horsley started first pituitary surgery, and nowadays we are operating clival lesions, and even all the lesions anterior to the foramen magnum can be approached with the help of endoscopic endonasal approaches. This diagram shows the scope of endoscopic approach. That is, we can operate olfactory cleft, then plenum, sphenoidal, sellar region and clival lesions, and furthermore cervico-occipital lesions. Skull base surgery is roughly divided on the basis of levels. Level 1 is plain sinonasal surgery, then level 2 is pituitary lesions, CSF leak repair, and level 3 can be extradural or intradural, which contains transorbital approach, transodontoid approach and transplanum approach. Approaches to skull base can be divided on the basis from which area we approach. It can be transfrontal, transcribriform, transplanum, transsellar, transclival or transodontoid process. And the most important thing is which instruments you require to do skull base surgery. Endoscopic skull base surgery requires use of dedicated sinonasal instruments along with video endoscopes. There should be a microdebrider to facilitate exposure time, particularly thymoidectomy. You may have ultrasonic surgical aspirators for tumor dissection and ultrasonic bone cutters, which make your work easier. Then you should have mortar equipped with long handpieces allow drilling of the thickest portion of skull base, for example orbital apex. In a case of orbital nerve decompression or optic nerve decompression, you should have angled bursts useful in frontal sinus surgery. Then hemostatic systems mainly comprise sheath, monopolar cautery and bipolar forceps. Diode laser is also useful, particularly during mucosal dissection. Navigation system are very useful in cases for intraoperative localization of tumors. Use of Doppler probe to locate larger blood vessels during operation. An endoscope without irrigation system has a much smaller diameter and therefore is easier to use and less traumatic in the nasal cavity. And long, small caliber dedicated instruments facilitate soft tissue dissection and intradural surgery. Approach to clival lesions can be transclival. It can be clival region can be divided into anterior, middle, and inferior, or there may be a complete clival removal. A transclival approach provides direct access to brain stem and vertebro-basilar arterial system. And indications for transclival approaches: meningiomas, chondrosarcomas, cholesterol granulomas, and mucoceles. What are the advantages of transclival approach? Is that it, first of all, it avoids the cerebral retraction and to decrease the incidence of injury to lower cranial nerves which pass through that area. And contraindications are when there is a small sphenoid sinus, you may injure ICA, decrease space between internal carotid arteries, making drilling the clival bone more difficult and risky, lack of multidisciplinary team cooperation and interaction, and the most important is lack of specialized instruments. Complication in transclival approach can be CSF leak, there may be nasal bleed, bleeding from internal carotid artery, intracranial bleeding, venous bleeding, cranial nerve injuries, infections, orbital hematomas, nasal synapse and nasal infections. Then how to approach spinomandibular junction lesions? That can be done by transodontoid approach. The most common surgical lesions which are present in that area are usually secondary to rheumatoid arthritis, and it has been firstly approached by Elfier et al. The major advantage of spinomandibular transodontoid approach is quicker recovery, faster return to oral elimination, lower incidence of bilopharyngeal insufficiency. Then for lateral lesions we can have transorbital approach. Transorbital approach may be used for SS, tumors located within the orbit. The dissection can be extracornal or intracornal. It is meant for resection of sinonasal lesions that are invading the medial wall of the orbit. For example, sinonasal malignancies, to decompress the optic nerve in the presence of unresectable intracornal pathologies, and to assess intracornal disease, the goal of dissection as for schwannomas and meningiomas. Endoscopic optic nerve decompression has been already taken by
So coming to the complications of skull-base surgery, see, if any surgery, there are few complications that will always occur. That is vascular complications, whether arterial or venous, neural complications, which are very common if in skull base, and then skull base defects. So coming to the vascular complication, arterial hemorrhages, they are the most common, and out of that the most common would be during endoscopic skull base would be from the branches of external carotid artery, specifically sphenopalatine and the maxillary artery. Bleeding from internal carotid artery, though rare, is very which has a mortality of almost about 14%, but fortunately if the surgery is done properly and with proper instrument, it is very rare, less than 1%, and in cases of expert hands it is as less as 0.4%. Now of all the things, internal carotid hemorrhage, internal artery carotid artery hemorrhage is of prime importance, though a rare complication, since the mortality and morbidity is very high. One should always be very careful, in which in the morning when the diagram was explained, the paraclival and the paracellar region is the most commonly involved, especially while dissecting the sphenoid sinus, where the injury is very common. So all the skull base or the fess surgeries, there is a prerequisite of doing a CT, nose and PNS, whether mostly a CECT in most of the cases, to see the anatomical structure inside. Once you know the battlefield, it will be easier for you to do the surgery and prevent any complications. So if there is a dehiscent carotid artery which can be seen here, or a dehiscent cavernous sinus, one can be very careful in preventing such complications. And as a surgeon, what we have learned is try to read the CT yourself, don't be dependent on the radiologist. So vascular complications, where next is venous.
during skull base, certain venous hemorrhages are inevitable due to presence of various venous structures which approach in the pathway. So for instance, in midline transsphenoidal approach, bleeding may occur from sellar meningeal layer, especially in the presence of a wide intracavernous connection. So depending on the approach, venous complications are not very tough to handle. Compression using materials like flow, seal, avatine and gel foam can also be used to prevent and manage such complications. In vascular complications, in the morning it was discussed, the most common also is anterior ethmoidal artery. The thing is, anterior ethmoidal artery, though very if injured can retract and lead to orbital hematoma and all. But what I have seen experienced surgeon, even if it gets injured, just compress the eyeball and wait for 5 to 10 minutes. Even if it's retracted inside, you won't have any further complications. This is one of the things that I learned while working with one of the senior surgeons. Nothing would happen if you just keep on compressing the eyeball for continuous 5 to 10 minutes till the bleeding or the clotting time, and it can prevent orbital hematoma. Now coming to the next, neurological complications. As and when we approach, since it is a skull base, all the neural pathways pass through this. So injury to the olfactory nerve, optic nerve and the optic chiasm in the region of the cellar and the suprasellar region. Oculomotor, 3, 4, 6 going beyond this optic nerve. Trigeminal injury, median nerve, most common, complete iatrogenic, which is very common. In the cribriform 8, in the cellar, suprasellar region, if you're doing parotid, depending on the base of size of the defect, there is a classification called as epsidodustic classification, where grade 0 is no leak is seen, grade 1 is a small leak without an evident diaphragmatic defect, grade 2 moderate leak, and grade 3 large diaphragmatic or dural defect which requires a pedicle flap for infections. Obviously, when you are operating in the skull base, proper sterilization and has to be maintained. Infections can occur which may lead to meningitis and encephalitis, so proper antibiotic prophylaxis. Operative and the post-operative management of the sinonasal tract is also very important when you're calling the patient for follow-up. Regular suctioning under vision, not blindly suctioning, that is one very important thing. So to conclude, first we need to remember that if you're going to do surgeries, complications are going to happen, but only do surgeries when you have received adequate amount of training. Complications can be prevented if you know or you are well prepared beforehand with the imaging, and nowadays navigation system is available. And complications, even if they happen, you have to address them and have to manage them accordingly, because surgery karoge to complication to hoga.